berseri membuatku rela hati. Ya Allah, Tuhan Rabbiku, Muhammad junjunganku, Al-Islam agamaku.
recited the Holy Quran. May Allah always bless us. Amen. Ladies and gentlemen, the next agenda is greeting speech. The speech will be delivered by Dean of Faculty of Health Science, University of Muhammadiyah Malang. And we please to Professor Dr. Yoyo Bukti Prasetyo, MKep SPK, to open this event. Time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Distinguished keynote speaker, Dr. Edward Sambutsi from the Faculty of Nursing, Monash University, Australia. Associate Professor Dr. Praset Sakwisri Praset from the Faculty of Physical Therapy, Mahidol University, Thailand. Professor Su Hua Wu, PhD, from the Department of Clinical Pharmacy, Taipei Medical University, Taiwan. Also, the invite speaker, Ibu Nur Aini, PhD, from University Muhammadiyah, Malang. Give big applause for the speaker. The Honorable Vice Dean 1, 2, and 3, and the Head of Nursing Pharmacy and Physiotherapy Program, respected colleagues, esteemed guests and participants. It is my great pleasure to welcome you all to the 4th Health Science International Conference 2025, hosted by the Faculty of Health Science, University Muhammadiyah of Malang. This year, we get under the theme Applied Technology for Sustainable Health. This theme reflects both urgency and opportunity. Around the world, technology is rapidly transforming healthcare from digital health and artificial intelligence to biomedical innovation and community-based application. Yet we are reminded that true progress must also be sustainable, inclusive, and accessible to all. Today, our distinguished speaker and participant, we will share insight, best practice, and research that bridge innovation with humanity. The conversation we start here can spark collaborations that extend beyond this room, contributing not only to scientific advancement, but also to help more resilient society. I would like to thank our international partner for joining us to the acknowledgement the hard work of the organization committee who made this event possible. To all participants, we encourage you to use this opportunity not only to learn, but also to connect, question, and inspire one another. Together, let us embrace technology as a tool, but never forget that the heart and health science is our commitment to human well-being. With that, I am honored to open the Health Science International Conference 2025. event be fruitful and inspiring for us all. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Mr. Dean. Now, ladies and gentlemen, to welcome our honorable guests and participants, we would like to present traditional dance. The name of this dance is Sorote Lintang. It is a traditional dance from Indonesia that symbolizes a woman's inner beauty and grace, like a falling star that brings light and joy. So, ladies and gentlemen, without any further ado, please welcome dance performed by nursing student from University of Muhammadiyah Malang.
Waton kondo arung kembyang tulondo Cincingan kiawan ono pendopo Keliaran rasa sepodo-podo pangilira Kukue bangsa
Foto tangiyo antena no lintang kemukus anggowo cahyo
Great performance!
Do you know, UMM consistently strives to provide the best learning experiences for its students. Do you know, this university currently have boasted international recognitions and achievements. Established in 1964, University of Muhammadiyah Malang has been well known for its beautiful natural landscape in the heart of Malang City. It was him Malik Fajrat, former Indonesian Minister of Education, who also plays significant on the excellent development of the university. UMM has achieved remarkable international recognition. The university consistently ranks among the world's and Indonesia's top universities. According to various rankings, including US World University Rankings, UI Green Metric World University Rankings, Global Metric, Applied HA, and many others. Moreover, UMM students excel in a wide range of fields, from arts and martial arts to technology and academics. Significant numbers of international students pursuing their study at UMM contribute to the university's vibrant of international atmosphere. Consisting of 11 faculties and 63 study programs, UMM is highly attuned to the challenges of the future, as evidenced by its numerous Centers of Excellence, or COE. These programs empower students to hone their skills and prepare for the demands of the global workforce. UMM possesses strong commitment to offer high-quality academic tenure and fostering strong characters for the next generations of students. This future endeavor meticulously reflected in various programs: leadership and character building program, foreign language of specific purposes or FLSP, centers of excellence, and other numerous international acceleration programs. UMM continuously engages in addressing global challenges through tangible initiative programs such as energy independence, eco-business, and community development programs initiated by Transformational Professor Program. The university's SDGs Center has been recognized by the Indonesian National Development Planning Agency, or Bappenas RI. Through these multifaceted commitments, UMM is dedicated to produce highly skilled and qualified graduates. This integrated approach demonstrates UMM's unwavering from Muhammadiyah for the nation.
Before we continue to the next agenda, we please distinguish guests and participants to have a coffee break at the side of this room. Thank you. Kami persilahkan kepada Bapak Ibu sekalian untuk melanjutkan ke agenda selanjutnya. Dimohon untuk coffee break sejenak di sisi ruang main hall ini. Terima kasih. Ladies and gentlemen, we are now continuing to the next agenda, that is keynote speaker session. The first speaker will be delivered by our first keynote speaker, Dr. Edward Zimbutsi from Monash University, Australia, and Mrs. Indah Dwi Pratiwi, Escope Nurse Master of Nursing, will be the moderator. To Mrs. Indah, time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning. Okay. Before we begin, let's confirm that Dr. Edward Zimbutsi is already join us via Zoom. Are you there, Dr. Zimbutsi? Can you hear my voice? Hello? Dr. Zimbutsi? Can you hear my voice? Okay, while we're waiting for Dr. Zimbutsi in the online platform, let me introduce myself first. My name is Indah Dwi Pratiwi, and I will be a moderator for the first session on behalf of the organizing committee of the Fourth Health Science International Conference held by Faculty of Health Science, University of Muhammadiyah. Our theme for this year is Applied Technology for Sustainable Health, challenges us to think differently, to collaborate across discipline, and to translate evidence into practice. So, Dr. Edward, are you joining us?
I can hear you.
Okay.
Can you hear me?
Yeah. So is my voice clear for you?
Hello?
Dr. Zimbutsi, yes?
Can you hear me?
Yes. Yes, we can
okay,
hear
I can
you.
hear you.
Okay.
I can hear you well.
Okay. So before you begin your presentation, let me first introduce you as the first speaker to the audience here in Indonesia. So it is my great pleasure to introduce our next speaker, Dr. Edward Zimbutsi. So he is a senior lecturer and senior research fellow at Monash University and Monash Health in Melbourne, Australia. He is a registered nurse and a prolific researcher whose work is dedicated to a profoundly important area in the area of optimizing care for people with diabetes and kidney disease. Dr. Zimbutsi expertise is not just a theoretical, but his impactful work has been recognized with numerous awards, including the 2024 Emerging Nurse Researcher Scholar Award for the Oceania region and the Monash Partners Award for Health Service Research. He is a respected leader in his field, currently serving as the international lead for Monash Nursing and Midwifery and as a board director for the Renal Society of Australasia. Today, he will be sharing his topic on insight from a new model of care for people with diabetes and kidney disease. Please join me in giving a very warm welcome to Dr. Edward Zimbutsi. So, Dr. Zimbutsi, the time is yours. You may begin your presentation.
Just confirming that you can see my screen.
Yes, we can see the screen here.
Wonderful. And thank you so much for the beautiful introduction. And I should say I'm overwhelmed to have an opportunity to be speaking to you today from Australia. I just wanted to acknowledge the indigenous people of the place where I'm working from here in Australia, and I do pay my respects to their past elders and present. And as you have seen, my interest is really around helping people with kidney disease and diabetes to live better. So I'm going to share a few things that I have done and achieved over the past few years with regards to this topic. I have got no disclosures to make today. But in essence, this is what I want to talk about, a project that I had an opportunity to work on. So I'll take you through the formative work that I have done that led to a bit of co-designing of some interventions that we thought would help people with diabetes and kidney disease. How we went about recruiting the participants for this project, and how we implemented the project. But also, if we don't evaluate the work, we want to know whether it is making a difference or not. So I'll share some thoughts around the evaluation aspect of this work. But just to bring some context here around diabetes, we know that this is really a big problem worldwide, with an expectation that around a 51% increase is expected by 2045 in terms of the number of adults with diabetes. And this map here does show you where the impact is likely to be. And we can see really from this map that even some countries which used not to have problems with diabetes, such as developing countries, are starting to have the impact, or to face the impact of diabetes. So very, very important that we really have some measures to manage this problem. We do know that when diabetes exists or brings, when diabetes occurs, it does invite its cousins, it does invite its relatives. And one of its cousins, which it wants to take along the journey, is kidney disease. So we do know that around 40 to 50% of people with type 2 diabetes develop kidney disease. And this is quite a huge problem, because it just becomes more complex to manage these people. So in terms of our formative work, we get to really sit down and say, okay, what is it that is preventing our people with diabetes and kidney disease accessing the health services that we currently have? What sort of barriers do they face? What sort of issues arise when, in terms of the provision of the care during that period? And we found that barriers to healthcare varied across different stages of kidney disease. For some of you who may not be aware of kidney disease, it's staged from early stages to late stages, where people require kidney replacement therapy, such as dialysis, and early stages where possibly nothing much happens except for monitoring. So when we looked at this trend, we realized that specific intervention is needed to be taken depending on the stage at which our patients are. So we also have shown that we went and reached out to people who look after people with kidney disease. And in our context here in Australia, we've got people like general practitioners. These are community doctors. So we ease down, we ask their perspectives regarding the barriers to health services by people with diabetes and CKD. And our general practitioners express expressed a clear interest in, in wanting to help out the situation for people with diabetes and CKD, and they actually advocated for our patients with diabetes and CKD, saying that they wanted to be, the principal healthcare providers, which was really quite good. And then we sought the perspectives of patients themselves in this qualitative study, because you can't do a lot without actually including the patients who are affected. And our patients told us that they preferred health services or a model where self-management was promoted, where there is access and where there is continuity and the continuation of care. They wanted a health service where psychological morbidity is assessed and is managed. So we thought that's good, that's really great coming from our patients. So we then thought, okay, with all this information that we have, now what do we do with it? We started thinking about the most appropriate model of care for this group of patients, those with diabetes and kidney disease. And in this publication here, we came up with a beautiful model of care. And what's important is that when I say we, it was a group of healthcare professionals that range from endocrinologists, kidney people, our patients, their family and relatives, stakeholders like Kidney Health Australia and Diabetes Australia. These are people who represent the issues of our patients. So they were all involved. Everyone was on the table, and we came up with this model of care where we put our person with the disease at the center and their family, and the things that they thought were important to them, like self-managed education, empowerment, peer education, and then how we support this through. So, with our general practitioners being the central people driving this, but also the peers, people, other people with the condition. But as I said before, Diabetes Australia, Kidney Health Australia were really key partners for our people with kidney disease. But we've also had outside this, the diabetes kidney service that we thought would be very helpful in terms of managing the complexities of this disease. This is where we have our specialists, in other words. This is the clinic where people would be referred to if they've got problems or for ongoing review. So we envisage that such a model of care would work for our people with diabetes and kidney disease. I will refer you to this publication then for further context. So what is unique about this model of care? It is a model of care that was developed in consultation with the people who have got the disease and the people who support the people who have got diabetes and kidney disease. It involved input from consumer advocacy groups, and it addressed things that were identified in our formative work, such as psychological morbidity. It's patient-centered, it's bi-directional. So the communication from the community or from the general practitioners to the clinic, it's bi-directional. Patients are seen in the clinic, and straight away their general practitioner knows what has happened in that clinic. So, and there are also some supports built around that clinic, like education sessions, telehealth, and a specialist outreach service, things that our patients would otherwise not have in the clinics they used to attend. So how about recruitment? How did we go about it? So we focused on patients who had both diabetes and kidney disease, EGFR less than 60. So in other words, they were in stage 3 and other later stages of kidney disease. And we drew these patients from 4 of our large tertiary referral hospitals here in Australia. And what do we measure? So we looked at the kidney disease quality of life, which is an instrument that has been used for quite some time now. It's validated and it's known that it measures what it's supposed to measure. We also measured what is called patient activation measure. Now, this is a tool that assesses the patient's knowledge, confidence in providing care to themselves or in looking after themselves. So very, very important tool that is starting to creep in, that is being used for people with kidney disease. We use the summary of diabetes self-care activities to assess their self-care and also obviously we collect demographic and clinical data for our patients. And appropriate analysis was used for each particular phase of the study. Now, as we just look at the demographics of our patients and the baseline data, we found that younger people actually were struggling in terms of their quality of life, and that female gender, being obese or normal weight, and more advanced stages of CKD were associated with lower scores of quality of life in one or more subscales, which identifying those subgroups of people with lower quality of life was quite insightful for us, because then we knew which people to target. In terms of activation, which I defined as the confidence people have, the knowledge people have, the skill people have to manage their own condition. We found that the level of activation was low in patients with diabetes and CKD compared to other chronic conditions. And older age and worse self-reported health were associated with lower activation. We also demonstrated that a higher level of patient activation was positively associated with overall level of self-care. So, that was a very great finding for us, because we had thought that, okay, what comes first? Patient activation, self-care. What do we need to do first? And this is pointing to us to say, if a patient can, if patient activation levels are reasonably high, our patients are likely to do well in terms of self-care. And diabetes and kidney are chronic conditions that requires patients to do a lot of self-care. They are only, or they only come to clinic or see healthcare professionals for a very, very small fraction of their time, and the rest they are at home looking after themselves. In this publication here, we showed that participation in diabetes self-management activities, which include general diets, exercise, and medication technique, were associated with increased higher quality of life. We went on to tease out some barriers, things that prevent patients from managing well. And in this publication, we showed that there were some. We reported that barriers to health care were associated with lower physical and mental well-being. And some of these barriers included low mood, feeling unwell, other life stressors, unavailability of home help. And it's interesting to say that this describes quite a significant number of patients who fall under this category of having diabetes and kidney disease. Most of them would have low mood and they would feel unwell. So quite significant barriers here. So interventions addressing these barriers may actually improve quality of life among patients with diabetes and kidney disease. We also wanted to find out the barriers, whether these barriers were associated with poor glycemic and blood pressure control, very, very important outcomes for people with diabetes and kidney disease. And we found that lack of patient perceived family and primary care physician support were associated with increased odds of poor glycemic and blood pressure control. So this is pointing to us having to involve patients as family, but also to have care that is person-centered, so that we can improve outcomes for our patients. So primary care physician support is very, very important. Before we introduce this model of care, our patients would be seen by any doctor who is available, and the GPs, general practitioners, were there and they were working very well, but the coordination with the clinic or the referral clinic where patients would be seen for their complications, it wasn't quite well streamlined. So, coming to the implementation of this model of care, we had to sit down and say, okay, this is a new thing that we want to do here in Australia. Who are the healthcare professionals we need to have in this model of care in this clinic that would look after people with diabetes and and kidney disease. So we found that having nurse practitioners was valuable because of the very important work that our nurses do, endocrinologists and nephrologists, among other staff. We had like podiatrists in there as well, educators in there as well. But we also set up the clinic in such a way that quality improvement activities would continue, because it's very important that we collect some data through auditing to ensure that we know where we are doing well and where we need to improve. In terms of communication, this clinic has got a phone advice line. General practitioners can pick up a phone at any given time and call the clinic and speak to someone and inquire and get a response regarding their inquiry. Moving on to evaluation of this module, we evaluated this clinic after a period of 12 months, so from 2015 January to August 2017. And when we did this evaluation, we were looking at patients who had gone through this service, this new model of care, otherwise referred to as the diabetes kidney service. And we used the similar tools, the tools that we use at baseline. So the kidney disease quality of life questionnaire, the patient activation measure, the summary of diabetes self-activities questionnaire, and appropriate analysis were carried for each particular study. So I'm going to go through a number of outcomes that we looked at as we were going through this evaluation phase. In this study, we looked at whether this service had a similar impact to people from different backgrounds in terms of their culture. Here in Australia, we've got a term called CUL, which refers to culturally and linguistically diverse backgrounds. Just to bring some context here, these are people who speak a language other than English at home. But they could also be born overseas. They could be a second generation. But there are a number of ways of looking at this. But basically, what we are saying is we would like to see whether if we've got a subgroup of people who don't identify themselves as proficient in English, and it's pointing to culture. They've got some cultural backgrounds that they are following, and whether actually they behave the same way in terms of some of the outcomes that we looked at here. This paper, in this paper, we focus on patient activation, and I'll just take you through the recruitment for this evaluation aspect, where we started off with 393 patients, and a lot of things happened there. But we had 290 with baseline that we thought was important for us to move on with the follow-up. And among those, 230 were from non-CUL backgrounds. In other words, just maybe say people who were born in Australia and were speaking English, and then CUL backgrounds. These were people who could not speak English well or were born outside Australia, just to bring that context there. At 12 months, we had 170 people remaining, 126 from non-CUL and 44 from CUL. And just to bring some context here, according to the survey that's done by throughout Australia in 2021, 1 in every 4 Australians spoke a language other than English. So in other words, 25% of people in Australia identify as from CUL background. So we found that when we examined or looked at this group of participants who were following up, they were reasonably, they were older, 67, and unlike a lot of other studies where we, or in kidney disease, where we've got more males participate. This study was or mimicked a lot of other studies in kidney disease. We have got more males participating, so 64% compared to 37%. And when we look at the distribution of CKD, it was quite what we expected in this population, with a few, around 20%, having end-stage kidney disease, including dialysis. Now, when it comes to patient activation, we had a mean activation level of 57. With activation, it can be measured from 0 to 100, with 0 being very low and 100 being where everyone wants to be. So our patients had a mean of 57, which is consistent with other studies in kidney disease. But you see that some other chronic conditions will have a mean palm of around 60, 65, maybe not so many getting 70. So 57. When we split this into two, non-cowed and cowed, we found that those non-cowed patients, those who identified as non-cowed had a mean of 59 compared to 52, the mean difference of 6. So our patients from cowed beggars, those who spoke other languages other than English, had a lower patient activation level, which is something that we were concerned about. So we did some further analysis, and this analysis again, using regression models, showed us that those who would identify as from cowed backgrounds were likely to score 6 or even 7 points lower than patients from non-cowed backgrounds. So this was just to confirm our finding from that baseline result. And after 12 months of running through the clinic, going through our model of care, we looked at whether the model of care would make any difference. So for those participants who were at baseline, demonstrated that there was difference in baseline. But when you looked at 12 months, we found that there was actually no difference in terms of activation level between our cohort, so the whole cohort. But when we did a subgroup or within group analysis, we found that there was actually a significant improvement in activation among those patients who were from cowed backgrounds, but there was no improvement from those from non-cowed. So we thought, so our intervention is actually sensitive to people from cowed backgrounds. So it's making a difference to people who don't speak English or who speak other languages other than English at home, which was really great to see, because this subgroup of participants, we know, doesn't do well across some other outcomes. We ran some further analysis with this Sankey plots. Now just to a bit of explanation here. With activation, it can you can actually categorize the activation scores into 4 levels. With level 1 being very low activation, and level 4 being where we want to be, very high activation. So level 1 to 4, with level 1 being low and level 4 being high. So when we did the same plots for the whole cohort of our participants, we found that at baseline, we had quite a good number of our participants in level 4, maybe 25% in level 4, but at 12 months follow-up, you can see that this shrunk a little bit. So that means now our model of care had some impact. We reduced the number of people in level 1 slightly, but what happened to level 4? Here we had maybe about 15% in level 4, where we want patients to be. And at 12 months follow-up, this grew a little bit from what it was at baseline. But I'll just show you some further analysis as well. When we looked at the two groups, non-cowed, those who speak English, and cowed backgrounds, those who don't speak English, looking at baseline here, there were quite a number who were from the non-cowed backgrounds, who were in level 1. Significant drops, when we look at 12 months follow-up, and level 4, possibly not much of a difference, as we've shown earlier, that for non-cowed backgrounds, the clinic did not really make a huge difference in terms of activation. But for those from hard background, at baseline, level 1, quite a huge number of patients, 30%, were in level 1. At follow-up, that dropped to possibly 20% in level 1. So great improvement, seeing our patients moving towards those higher levels of activation. And you can see that here when you look at the level 4, where we want patients to be, that at baseline, a very small fraction or proportion of our patients were in level 4, those from our backgrounds. But when we get to 12 months follow-up, we double the number of people or number of patients in level 4. So the clinic doubled the number of patients in level 4. In other words, very significant improvement, especially for people from CAUD backgrounds. So the key message here is, among patients with diabetes and chronic kidney disease, those from CAUD backgrounds report worse activation scores if we don't do anything. But interventions that target people from CAUD backgrounds are needed to address, some of these disparities that exist in patient activation. And as this study does open up an opportunity to explore potential causal and some mediating factors for this relationship. How about quality of life? Because quality of life does matter. It's very important. So we look at quality of life at baseline and also at 12 months follow-up. And just looking at some baseline characteristics here in terms of people who participated in this study and those who did not, or sometimes you can be so selective and those who participate in have high quality of life because they chose to participate. So we looked at our participants who completed the study and those who dropped out. There was no significant difference in terms of these clinical and demographic characteristics listed here. So we were actually comparing apples for apples and oranges for oranges when we looked at this cohort of participants. These box plots are just showing what was happening across the quality of life, where we look at symptom problem list, early stage kidney disease, effect of kidney disease, burden of kidney disease, physical composite summary, and the mental composite summary. So as you can see from these plots, not so much in terms of difference before and after the intervention across these subscales of the quality of life measure. Okay, how about when we look at maybe before I go any further, I should say this finding is very important because it's known that scores, quality of life scores for people with kidney disease, especially when they've got diabetes, they would deteriorate with time. So keeping them at the same level was a very, very important finding for our clinic. We then looked at whether there were any differences by gender, and as you can see here, for males, of course, not so much of a difference when we looked at the symptom problem list, but when we looked at this was at baseline, but when we looked at females, there was quite a difference with them. Females doing better on follow-up at 12 months. We looked at the physical composite score, the physical, the exercise, the walking, and we found that for males, we knew that males would score slightly higher than females, but before and after, there was a bit of a difference in terms of the scores deteriorating for males there, but for females, it was great to see the scores improving after the 12 months of the clinic. Now, some key messages here is that the quality of life, health, quality of life will deteriorate with time in this cohort of our patients. And quality of life of patients with comorbid diabetes and CKD attending our model of care was maintained over the 12 months period, which is really a very important finding. An integrated diabetes and kidney disease model of care, like ours, may improve some quality of life subscales in women. Okay, now this paper here evaluated some of the hard outcomes that included, glycemic control, mortality, and self-care. And you can access the full paper just to get a bit more information regarding what we evaluated. So I'll just give you a high overview here. Patients who went through the clinic, 393, but a lot of things happened. And after 12 months, we had full outcome data that ranged from 137 to 170 for these outcomes here, eGFR, HbA1c, self-care scores, and patient activation. But what we did here is that we also got data for patients who did not go through our clinic for comparison reasons. So we had patients who chose to go to other clinics, who never got into our clinic. So we wanted to see whether our clinic actually made a difference by making comparisons against that cohort as well. So that's very important to take note of. So patients who went through our clinic, we otherwise refer to them as having had the intervention of the diabetes kidney service. And those who did not go through our clinic, they did not receive the intervention. So during that period in time, 196 participants went through our clinic, and 7,500 did not choose our clinic, or they were being treated in other clinics. And when we look at some of the hospitalization indicators here, it's important to really note that in terms of frequency of admissions, those participants who went through our clinic were likely to be hospitalized. And the reason for that, we said our clinic improved things like patient activation, self-management. So they knew if they were unwell that they needed to go to hospital. They knew that they needed to seek medical attention, which is a very, very important concept, especially with people with diabetes or any complex condition. They were less likely to have things like major coronary events, which is great, and they were. When we look at things like the rate of death, they were less likely to die. It's a very important point, a good point. When they got admitted, they were likely to stay less in hospital compared to people from patients in the non-intervention group. So they are likely to be hospitalized, but to get out of hospital quicker, because they are going to hospital early to avoid complications. So they are discharged quicker. This is what we want to see in an ideal world. So their length of stay was shorter, which is really great. Now, when we look at guideline recommended care, because that's very important, it doesn't improve our patient outcomes. So we found that after 12 months follow-up, there was a significant improvement in terms of our patients meeting the guideline recommended for starting meals, annual eye examination, and food examination. We also looked at changes in self-care and patient activation for 12 months and follow-up, with significant findings found in terms of the composite self-care score significantly changed. This was when we put all the sub-scores of self-care together, so there was a significant improvement. And then we looked at what was occurring in both women and men, and again there was significant improvement in self-care. How about patient activation? There wasn't much improvement in terms of activation, even when we had the two groups split apart. How about changes in systolic blood pressure, diastolic blood pressure, and eGFR? So there was no significant change in systolic blood pressure as well as diastolic blood pressure. But very important though to note that in terms of the eGFR, it means we managed to have our patients maintain their levels or wherever they were in terms of the stage of CKD, because it's a very important outcome actually that will delay the progression of CKD, chronic kidney disease, and that's what we did through this clinic. In terms of, and this also can be replicated when we look at what was happening to patients in terms of ACR. HbA1c, a very important marker in terms of diabetes. So the higher, the worse, the lower, the better. So we can start at baseline, it was around 8.2. And as we followed our patients up for 12 months, we found that there was a significant improvement in terms of HbA1c from baseline to 12 months follow-up. So very, very important outcome that we all hoped for. And what are the key messages here? A co-designed person-centered integrated model of care improves or can improve all-cause mortality, kidney function, glycemic control, and self-care for patients with diabetes and CKD. And we did achieve guideline recommended care in terms of starting meals, eye, and food examination. But we also think that it's very important that we upskill the multidisciplinary team members. If this to run well, or if we are to provide high quality care to this group of patients. Exploring or evaluating the outcome of this service from just a quantitative approach may not be enough. So we thought, okay, let's go back to the healthcare professionals. Let's go back to our patients and ask them how they felt about this clinic. And we did this after 12 months. So we explored the experiences of our patients and the healthcare providers within this integrated diabetes and kidney service. We had like 6 clinic participants, we had 5 primary healthcare professionals, and also 21 patients in this qualitative study. Now, our participants told that this service improved access to services, there was better integration and continuity of care, the perception, and there was perception of improved health and management of health. The process of care was so much streamlined, but they wanted us to further clarify. This was actually a comment from a participant who was a patient who said if there was some way that they could maybe, I don't know, shorten the waiting time to give an individual, or it's difficult. I know to give everybody individual times. This is about the process in the clinic itself. Health professional education was also identified as an area of improvement. We know that education is ongoing. You never come to a point where you say, we are now educated. It's something that is ongoing. In terms of patient self-management, we had a comment from a patient as well who said, because every time you consult a kidney doctor or a diabetic doctor, they only concentrate on that curative method, not on the preventive one. So very, very important point that came from our patient participant. But our clinic has got educators, our clinic has got nurse practitioners who have got a broader scope besides focusing on the curative approach. So we are hoping that this is being met in this clinic. So if you look at these themes that came up from this qualitative study, you can see especially the strength. You can see that they are addressing our formative work. The first few papers that I presented where patients were saying we want to see improved access, we want to see this. It's now coming up nicely together where the clinic is or the service is meeting the concerns that were identified earlier on. So overall, health professionals and patients reported that a co-designed integrated diabetes kidney service improved integration of care and improved health and management of health. However, some aspects of the process of care, health professional education, and patient self-management can be improved, and we believe this is something that is ongoing. So this highlights the need to address some patient and health professional as well as health care system barriers to health care. Now, in conclusion, involving patients as well as caregivers or carers or cadres in co-designing improvements to healthcare is key to the success of our model of care, and I believe any model of care. So interventions are enhanced if delivered in a patient-centered model of care, because we know that such a model of care can address personal, can address health professional and healthcare system barriers. We also know that it's very important now to streamline the collection of patient-reported outcomes data. Often we do research and go away, and then we come back 10 years later, there's nothing happening. So it's very, very important that we have, or we embed quality improvement aspects in the clinic, where the collection of data happens, without significant burden, without a lot of resources needed to achieve that. So we do understand that this may not be financially viable to continue overseeing such collection of data, but very, very important if there could be even third parties who can come on board and possibly chip in terms of making sure that the clinic or such mode of cares you've got data that is collected regularly. With that, I would like to acknowledge the people who have been very, very important to this work that has made a difference to the lives of our patients in Australia. So these are the supervisors for the PhD project which I did as part of this work, Professor Sophia Zungas, Professor Peter Kay, and my colleague, Dr. Clement Law, project management and support offered through Dimitra Giannopoulos, and the Diabetes Remote Project Steering Committee, who are scattered around Australia, and all the participants. Without them, this project would not have been successful. And of course, the National Health and Medical Research Council for funding this project. Thank you so much.
Thank you, Dr. Simbusi. That is an interesting topic about integrated model of care for diabetes and kidney disease. So, dear participant, it is now the time for you to asking a question. So, if you want to ask a question, please raise your hand and then mention your name before asking. For those in the room, please make your way to microphone, and for the participant in the virtual platform, you may also ask question for Dr. Simbusi. Hello students, do you have question? Yes? Okay, please come forward. Please state your name first before asking.
Check. Okay. Let me introduce myself. My name is Bintang from nursing student. My question, according to the studies you mentioned before, the barrier to health facilities could make the patient less likely to report their self-care. Would you please explain what the barrier is that makes patients less likely to seek health care? Could you give explanation about the term activation in the previous study?
Okay, Dr. Simbusi, Are you ready to answer question? It is about,
Yeah.
yeah, okay.
Uh, very sorry, I could not hear the question. It's quite
Okay. Yeah, let me
Certainly.
repeat, let
Yeah.
me repeat the question. So is my voice clear? Can you hear my voice?
I can hear you just a little bit, not very clear.
Not very clear. Okay, the question is, could you please explore more about the term activation to overcome the barrier that make the patient less likely to have self-reporting? So the term activation to overcome the barrier that the patient is is less likely to have a self-report.
I'll just rephrase because I don't think I have. Oh, okay. Thank you for typing the question. Thank you. Just seeing it in the chat. Okay, so the question here is the barrier to health care facilities could make patients less likely to report their self-care. Could you explain what the barrier is that makes patients less likely to seek health care? Thank you. Such a great question. There are a number of barriers that can or that are involved in terms of accessing health care in our context, and I believe in other contexts as well. Number one, it could be even the physical barriers themselves. Here in Australia, there are things such as how to get to the healthcare service in terms of car park, in terms of transport. But we can also go to personal barriers, things like language, culture, cultural barriers. Such things, they play a very, very important role. There could be things or other barriers as well to do with the healthcare professionals themselves, like our patients, told that they wanted to see one health professional every time they go to clinic, which may be impossible, but in an integrated clinic like ours, you have got a cohort of healthcare professionals whom patients get used to, and they are likely to see every time they come for their review. So they are likely to disclose their difficulties with self-care to such a group of healthcare professionals, because it's all about trust here. When they trust the system, when they trust the healthcare professionals, they are likely to disclose where they are having problems and get help. There is another question which I can see in the chat, which says, could you give explanation about the term activation in the previous study? Okay, let me do it very simple here. So the term activation has been around since 2004, 2005. Started off by a lady called Hibbert in the US. Activation refers to whether one has got knowledge, whether one has got the skill, whether one has got the confidence to manage their health. Now, let's say the person has got diabetes and they need to inject themselves with insulin. How you apply activation is, do they actually have knowledge about how much insulin they need to grow into this needle? Are they actually confident about this whole procedure? But not only that, do they have the skill when it comes to the injection itself or even growing the injection itself? So that's activation for you, patient activation. You can apply it in any context. So the knowledge, the skill, and the confidence a person has in managing their health.
Okay, is that all? Thank you, Dr. Simbutsi. Is there any other question? Yes, one more? Okay, please come forward. Yes, please come forward. We have one more question, Dr. Simbutsi. Is that all right? Yeah. Okay. One more question.
Okay. Let me introduce myself. My name is Juan Fernanda Mardika. I wanna ask one question. What is the intervention you gave in your previous study to improve the quality of life? And could you explain more about the methods?
So, Dr. Simbutsi, could you please describe more or elaborate more about the intervention to improve quality of life?
Okay, thank you so much, and thank you for typing through the question in the chat. So let's go through the question again. What is the intervention you give in your research to improve the quality of life? And could you explain more about the methods? So the intervention that we give, so maybe let me say the status quo or the usual care is that patients would go to a diabetes clinic, they get seen, they are told to come back in 3 months, they come back, they see a different doctor, they go away. They go to a kidney clinic, they see a kidney specialist, they are asked to come back in 3 months, they go away, they come back, possibly they see a different person who tells them something different because they don't know them very well. Now, the intervention that we have through our diabetes screening service is that it has got all the professionals who have to anything to do with diabetes and kidney disease under one roof. So it's one clinic. One clinic. So a patient gets seen for their diabetes problems. They get seen for their kidney problems. They get seen for their education problems. So all under one roof. We have upskilled the staff who see them there. So an endocrinologist could see them for diabetes, but as well as for kidney problems, and vice versa. A kidney specialist can see them for their diabetes and kidney issues. That's the intervention and the self-management education that is associated with it. Now, when you look at the concept of quality of life, it's the tool that I've described before. It's quite comprehensive in that it doesn't just look at one aspect. It does look at things like symptom problem list, where you look at how well your patient feels in terms of the symptoms from a disease. So you believe that if the clinic is managing their symptoms well, they will report higher scores on the symptom problem list. There are also subscales like the burden of kidney disease, the physical aspect of their quality of life is another subscale as well. So as I've shown in the data there, so far we've shown that the clinic can potentially improve some subscales, but also for some groups of participants, and most importantly in this case, women who tend to report lower quality of life in this regard.
Okay, thank you for your answer, Dr. Simbutsi, but unfortunately, that's all we have time for question and answer session. Thank you for your excellent question for the participant. So we are now moved to the end of our first session. Thank you once again to Dr. Simbutsi for the insightful presentation. We truly hope that in the future you can come visit to our city of Malang. We'd be honored to welcome you here. That brings us to the end of the first session. I'd now like to hand over to our Master of Ceremony. Thank you all. Assalamualaikum warahmatullahi wabarakatuh.
second speaker will be delivered by Professor Prasad Sakul Sri Prasad from Mahidol University, Thailand, and Ms. Nikmatur Rosida, SFT MSc PT, will be the moderator. To Ms. Ninin, time is yours.
Oke, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, speakers, presenters, and all participants. Welcome to the HSIC 2025. It is my great pleasure to introduce our second speaker here for HSIC 2025. Before I do, I'd like to take a moment to express my personal enthusiasm as this second speaker is not only a distinguished expert in their field, but also my former professor and my mentor in my master program at Mahidol University, Thailand. Ajahn Prasad, hello. Can you hear me well?
Yes, thank you, Nikmatu. I can hear you clearly.
Okay. I would like to introduce our second speaker. Ajahn Prasad is highly respected expert in musculoskeletal physiotherapy, known for their impactful research and dedication to advancing knowledge in our field, especially in the intervention for musculoskeletal pain, electrophysical modalities for pain, and then also in the functional improvement, also function assessment in individual with musculoskeletal conditions. Today, Ajahn Prasad will be presenting and sharing with us his expertise about the high-intensity laser therapy for musculoskeletal pain, a subject that is relevant to our themes for today's conference, which is the applied technology for sustainable health. Without further ado, please join me in welcoming Associate Professor Dr. Prasad Sakulsi Prasad. Professor Prasad, actually I call you Ajahn Prasad. The virtual stage is yours.
All right, thank you very much, and good morning, ladies and gentlemen. Today, I would like to share my experience and my basic knowledge about the high-intensity laser therapy. This is very good and effective modality for managing musculoskeletal pain. So I'm not sure at the floor on site, could you hear me clearly, right?
Yes, Ajahn.
All right, thank you. So I move on. High-intensity laser therapy for musculoskeletal pain. Okay. So I would like to share with you the basic principle of the laser components. For the laser component, we have lasing medium. The lasing medium is an active medium that we commonly use, for example, ruby, helium neon, gallium diodes, or carbon dioxide. Also, we need the second thing is the energy source that we can use electric current or chemical reaction. And the third component is mechanical structure or resonant cavity. So the mechanical structure is a chamber or mechanical structure, okay? So we need three components. We can generate laser for any purposes of the laser to use. So the laser is the abbreviation that is stand for the light amplification by stimulated emission of radiation. All right. Shall I share you with the basic principle how laser be generated? Okay, so the laser is generated from the active medium. All right, we have the active medium, and we need an external energy source to emit to the active medium or lasing medium, okay? An external energy source deliver energy to the atoms of a special material known as the active medium. This energy excites the electrons in the atoms, causing them to jump from a lower energy state to a higher energy state. So we can call it excited state. For a laser to work, the majority of the atoms in the active medium must be in this higher energy state. All right. So an excited electron can spontaneously fall back to its lower energy level. You can see on the right hand side. Okay. When it comes into the lower energy level, it releases a particle of light called a photon. If this photon happens to pass by another excited atom, it can stimulate that atom to also release a photon as well. Crucially, the newly released photon is an exact clone of the first one. It has the same wavelength, direction, and phase. This creates a chain reaction. All right, we can see that, okay, in the diagram at the upper part, this is a mechanical structure. We have the lasing material or lasing medium inside, and then we pump the energy inside, and it releases a photon here, right? And the chain reaction generates photon and photon and photon more and more in the chamber. So this active medium is placed between two mirrors. We can see two mirrors on the left and on the right hand side that form an optical cavity. The photons bounce back and forth between these mirrors, passing through the active medium many times. Each pass triggers more stimulated emissions, rapidly amplifying the number of identical coherent photons here. So at the figures, we can see from the figure 1, 2, 3, 4, and 5, we have the coherent photon inside that multiply by many photons inside. And then we push the photon to release, we can see the coherent laser beam outside the mechanical structure. All right, for the laser, we have this characteristic that is very special compared to other light. So the laser is, the first one is a monochromaticity. The monochrome means that laser has just only one wavelength. The second special is collimation. The light of the laser beam is collimated. It means that the lights go parallel, not divergent, not convergent. And also the phase of the laser is coherent. So we have both spatial coherence, that is same direction, and is the same phase, or we call temporal coherence. All right, according to the monochromaticity is according to the laser that generated by the lasing medium, that is just give us only one wavelength that the lasing medium gives, right? So for example, like we use helium neon, it just generates, like for example, 800 nanometers only one wavelength. And this is a light beam that we call collimation or collimated, that is in the upper part of the diagram. So the lasing medium generates the collimated light beam of the laser. So it's not diverging, it's not converging. All right, for the laser is the light. Also, the physical properties of the laser is as well as other light that we have four things. When we emit the laser to touch to the skin of the patient, the first reaction is the reflection, right? When we just emit the laser to contact to the skin, some of the laser light just reflected outside the skin. So this is the number one at the diagram. So this is the loss of the lasing power. We lost it by the reflection. Also, we have the rays of the laser. We can get it into the number 2, 3, and 4. The rays of the laser after the reflection is just transmit inside the tissue. So this is a transmission. Number 2 is transmission. Also along the way, we have some scattering in the superficial layer of the skin of the tissue. And also for the target tissue, it finally absorbs the laser. We call it absorption. So we need absorption to be more than reflection. The way to reduce the reflection, we can contact the laser close to the skin, that it promotes the absorption to the target tissue. And also, we can place the probe of the laser perpendicularly, that just reduce the reflection according to the cosine law. All right, we move to the part of the laser therapy, okay? So when we use laser, we gonna understand that our tissue, we have chromophore, okay? The chromophore is the part of molecules at our cell, as our tissue. The chromophore can absorb laser, can absorb the photons, okay? So or can I say, like, mostly type of the tissue have the chromophore itself, okay? Especially for the melanin, hemoglobin, and water. The chromophore absorb laser is just turn the chromophore to the molecule to be excited state molecule. After that, it just create the photo product, okay? And the absorption of the photon just leads to the biochemical reactions. It leads to cellular changes, and when many cells involved, it just create the organ response. All right, we mentioned about the melanin, hemoglobin, and water that enrich with the chromophore, okay? Besides the target tissue, these three structures, melanin, hemoglobin, and water, has a lot of chromophore, okay? So shall we know that the ability of this melanin, hemoglobin, and water, it love particular wavelength, okay? So for the water, it just absorb a lot of the photon at the wavelength greater than 1000 nanometer. So we can see the graph is in the blue line, that hemoglobin absorb very well at the wavelength of the laser or any light greater than 1000. Okay, you can see that the graph is peak, right? More than 1000, 2000, 4000. Water absorb very well with the chromophore. For the melanin, it absorb well for the wavelength less than 400, right? So the wavelength less than 400 is the UV or ultraviolet. That's why we get darker at the skin when we absorb the sunlight, because this is the action of the melanin. And also for hemoglobin, hemoglobin absorb well as 400 nanometer as well. So when we generate the laser for the laser therapy, that we need the energy to touch to the target tissue, we need to minimize the effect of melanin, hemoglobin, and water. So we can see the graph that the range that hemoglobin, melanin, and water work not well is between 800 to 1000. That is why the lasing medium for laser therapy, we're gonna use for the wavelength of 100 and 1000. That is very appropriate because it's minimizing the effect of melanin, hemoglobin, and water. It's just delivered directly to the target tissue. Okay, for the biostimulating effects, it has been reported that the wavelength between 630 and 750 nanometers have a biostimulating effect. All right, nowadays we talk about high-intensity laser therapy, and we also have low-level laser therapy in the past. For physical therapy, we have used low-level laser therapy or LLT, and nowadays we move on to use high-intensity laser therapy. For both LLT and HILT or HILT, they have the same photochemical interaction. Photochemical interaction is about the creation of ATP, okay? So it's related to the mitochondrial activity, as we know that mitochondria produce ATP. So for LLT and HILT, both create ATP. So ATP is very essential for our cell, for the cell production, for the cell division, right? And it just promote healing. However, for the HILT, have two things is photothermal and photomechanical. The photothermal is related to the circulation improvement, it's related to microcirculation. And also HILT can create photomechanical interaction. The photomechanical interaction related to the extracellular matrix movement. It promotes lymphatic circulation, and it can reduce edema, okay? So for the LLT, just only photochemical, no photothermal, no photomechanical, because of the power of the LLT is so small, not create the second and the third. All right, when we talk about the biological effects of the laser, okay, for especially for the huge biological effects of the huge, we think we talk about the photochemical interaction that we mentioned before. So it's related to enzymatic activation, it's increase of ATP production, it rebalance cell metabolism, optimize sodium potassium pump function, and also increase pain perception threshold. So it's increase the threshold for the pain. For the photothermal interaction, is promote circulation for the better nutrient and oxygen contribution. So it's related to the cell oxygenation. And also for the last one is photomechanical interaction. Is produce the extracellular matrix. Okay, the ECF or extracellular matrix is just like a connective tissue that support the cell and make the cell linked together stronger, and also promote lymphatic circulation, reduce edema, and promote the microcirculation reactivation. All right, as we know that, okay, we have photochemical effects, and also the wavelength, for example, 808 nanometer significantly increase the activity of mitochondrial respiratory chain, falling in the secondary absorption peak of cytochrome oxidase. And for 905 nanometer wavelength, it significantly increased the activities of mitochondrial respiratory chain as well, at the complex 1, 2, 3, and 4, and succinate dehydrogenase. This is from research, okay? So what is the benefit of this? The increase of the mitochondrial activities just promote the tissue healing. So it's make the process of the tissue healing go faster, and then the patient feel, you know, like a pain reduction very well and very quick. So this activate mitochondria, increasing in ATP synthesis and accelerate of tissue healing. All right, it also promote anti-inflammatory, anti-edema, and analgesic effect as well. So it's increased anti-inflammatory protein, or we call NLRP10. The research also showed that it inhibits the activity of caspase-1 and the protein complex picard. And also it promotes the maturation of the inflammatory cytokine interleukin-1 beta or IL-1 beta and interleukin-18 or IL-18. And also the last one is inhibits the production of pro-inflammatory interleukin IL-1 beta and IL-18. So it promotes anti-inflammatory substance, and it reduces or inhibits the pro-inflammatory cytokine or interleukins. So this effect has the benefit to reduce edema, has the effect to reduce the inflammation, and also have the analgesic effect to reduce pain. All right, we know the biological effect of the laser that just try to promote healing, decrease pain, decrease edema, and reduce inflammation. So shall we talk about the techniques of application? I think I just suggest you to stick on or rely on the manuals that if your institute or in your clinic have the high laser, you're supposed to read to the instruction or the manuals of each model, each laser instrument, because some manual say that this instrument need the distance, for example, like 5 centimeters, or this instrument or this laser machine can use closely or contact to the skin. So it depends on the instrument. Okay, just read the manual first. So if your instrument or your laser can use both contact or non-contact, okay? If you can use both non-contact and contact. For example, if you use for the non-contact technique, I suggest you to have the distance between the probe and the skin less than 0.5 and 1 centimeter only, because it just if the distance is not so wide, it reduces the scattering, it reduces the reflection. So the laser beam can penetrate through the tissue very well, not so wide, not so distant. And we can use the scanning technique. You can scan the laser from left to right, from up and down, or in circular motion. Okay, we call it manual scanning. We can use the gridding technique, or we can just put the grid, like we can use the laser for the one grid one by one, okay, from one point to another point. And for the contact technique is better than the non-contact technique because it reduces the reflection. If your patient's skin is good, if the machine can use for the contact technique, so the contact technique is suggested because the laser probe directly contact to skin, okay, and the laser beam can penetrate very well to the deeper tissue. This is an illustration, for example, that we use laser, right? For at Mahidol University, we have this model. So we can use the laser contact to the patient's area. So in the upper picture, we treat the elbow, and the lower picture, we treat the low back pain at the lumbar area. Okay, I think for the laser therapy, that is very easier, when we compare with shockwave diathermy, when we compare to ultrasound therapy, I think laser is easier because other parameters is fixed by the machine. So the thing for us is just to select the optimal energy dose, okay? So what is the optimal energy dose? We can read and we can study from the World Association of Laser Therapy, or the WALT. They suggest us that for the optimum dose for laser therapy, for this conclusion is for low-level laser therapy, okay? However, we can also apply it for the hilt as well. For example, they just suggest us, for example, like a carpal tunnel syndrome here. They suggest for 12 joules or covering in the 2 or 3 square centimeters, okay? So we know that the area for the carpal tunnel syndrome is not so big. It's just the area about 3 square centimeter or 2 square centimeters only, something like that. So according to this principle, we can divide, okay, 12 joule divided by 3 points or 3 square centimeters. So we get to know that, okay, it suggests like 4 joules, okay, 4 joules per 1 square centimeter. So can use this principle to apply to other area. So when you treat your patient, you can identify the area to treat with laser. So if the area of application is so big, for example, we have like 4 centimeter multiplied by 5 centimeters. So the total square is 20, right? 20 square centimeters. So we can use the principle of 4 joules per 1 square centimeters. So for this area, we need 20 multiplied by 4. So the total joules is 80 joules, or the optimum dose is 20 joules, something like that. And you can see that in the deeper structure, for example, like hip here, the WALT suggests 40 joules for 4 square centimeters. So for the deeper area, it means that the WALT suggests us to use more joules, right? So for this principle, we can divide 40 joules by 4 square centimeters, or we get the result 10 joules per 1 square centimeter. So we can apply that, okay, if we treat the deeper structure like a hip joint or deep back muscle or deeper structure of the body, we can provide more joules like 10 joules or 8 joules, okay, per 1 square centimeters. So we can apply this when we gonna treat the deeper structure, okay? Again, in conclusion, for the superficial structure, we can apply 4 joules per 1 square centimeters, and for the deeper structure, we can apply 8 or 10 joules per square centimeters. All right, for the physiological effects of the laser, we say that, okay, it's increased mitochondrial membrane potential, and also the mitochondria produce ATP. The research has been reported that laser can successfully increase MMP and ATP, and also it can synthesize collagen. It can decrease swelling because it's just promote lymphatic vessels and promote the phagocytosis, okay? And it can create reversible hyperemia. It can kill some bacteria, so it can decrease microorganisms. So this effect is good for the wound healing. So if you have some patient with a wound, you can use laser for wound healing, for example, like a diabetic wound, or some patient that come for the PT unit for the wound healing care. And also for the last one, laser can reduce pain, okay? Okay, so this is the study from Ferraresi in 2015. They study the effect of the laser and they use the cell, okay? This is the C2C12 cell from the rat, and it's used some substance we call like tetramethylrhodamine methyl ester or TMRM to stain, okay? This substance can capture the mitochondrial membrane potential, okay? And it show us in red, okay? So it's come to red, that is, like a binding of the TMRM to the substance that create from the mitochondrial membrane potential. So after the radiation of the laser, the research showed that the TMRM come more after the laser at 3 hours and 6 hours, significantly, like 2 or 3 folds compared to the beginning. And the TMRM still lasts, but it's just close to the beginning at 24 hours. So this is real that, okay, when we use the laser for the laser therapy, the patient get more MMP activity at 3 and 6 hours after the treatment. And also the result for the ATP, that is in accordance with the MMP, right? Because MMP produce ATP. So the ATP comes significantly as well at 3 hours and 6 hours after a radiation, and is reduced at 24 hours. So the phenomenon of the laser to produce ATP at the cellular level is successfully and is real and evident by the previous study. Also for the pain modulation, laser therapy, both low level laser therapy and high laser can enhance pro-inflammatory cytokine TNF alpha proliferation. Also it promote the maturation and motility of the fibroblast. So the fibroblast is a good substance that is just divide to the collagen later, and the collagen can promote tissue healing. So the laser can increase fibroblast growth factor. Alright, laser also promote lymphocytes to proliferate rapidly and increase epithelial cell motility. So the lymphocytes come to the wound area, to the injury, and the wound sites close very quickly. And also the laser can promote the activity of the macrophage. So the macrophage, the roles of the macrophage is to do the phagocytosis. So the phagocytosis is just to destroy the debris and the waste at the injury, at the injured cell or at the wound area. Also, because of the laser, not only to promote tissue healing, but the laser can modulate pain immediately by reducing arachidonic acid. Okay, laser can reduce arachidonic acid release. That the arachidonic acid is a substance to create prostaglandin, leukotriene, and bradykinin later. So laser can inhibit the release of the arachidonic acid. So the arachidonic acid is reducing in the amount significantly. So we have no more prostaglandin, leukotriene, and bradykinin. So we have no substance to irritate the pain receptor. Also, laser can alter nerve conduction velocity and stimulate and activate the production of endogenous endorphins. So the production of endogenous endorphins will have the effect to the mu opioid receptors, and the effect of these can prevent the action of substance P. As we know, this is a regulation to the spinal level that can modulate pain, can inhibit pain perception. Alright, we know that this is substance that can stimulate or irritate the nociceptor, as we mentioned before, and also can create the increased sensitivity as well. So if we cut this substance, it's just to reduce the irritation of nociceptor, so it's inhibit pain. Alright, it's also from the endorphin. Endorphin just inhibits substance P. So the substance P cannot function properly at the substantia gelatinosa at spinal cord level. So it's just inhibit the pain perception at the thalamus. All right, we talk about the effect of the high power laser. According to the literature reviewed, the high power laser therapy can help us in nerve recovery, pain reduction, inflammatory response, muscle recovery, damaged tissue repair, and edema management. For the nerve recovery, the research showed that laser help in restoration of the myelin sheath and also synthesize the HNRNPK protein, which is very essential for axonogenesis or generate the axon. And also it synthesizes M2 macrophage, by which the M2 macrophage is the anti-inflammatory macrophage that is contributes to the prolonged inflammatory response, and this may have negative effects on tissue preservation and axon regeneration. Okay, so it just reduce the number of the it promote the release of the M2 that in the normal situation that the M2 macrophage release not so much, but the laser can create to promote the release more of the M2 macrophage that promote the tissue healing later. Also for the pain reduction, laser just try to remove the glutamate. Okay, according to the previous study, it's reported that increase in the level of an important glutamate transporter or EAAT2, thus favoring the neurotoxic substance of glutamate reabsorption. It helps to reabsorb the neurotoxic substance of glutamate. So this effect can reduce the pain. Okay, so it's considered as the glutamate is a substance that the nerve cell used to send signal to other cells at central nervous system, and the laser action on glutamate removal can induce the prompt block of the pain symptom. Also for the inflammatory response, the synthesis of anti-inflammatory response protein, we call it NLRP10. This is an anti-inflammatory proteins. It helps in the reducing of the inflammation mediators, the reduction of two inducible enzymatic pathway for the COX-2 and INOS. For the COX-2, this is create for the inflammation, so it's just inhibit COX-2 or COX-2 inhibitor. So the laser has the effect of the COX-2 inhibitor as well, that produce inflammation mediator. That if we have COX-2 to do its function, right, COX-2 will release prostaglandin and nitric oxide, the COX-2 and INOS. So it just reduce the inflammation. Also for the laser, it's just promote the muscle recovery. The laser can increase the MyoD and alpha enolase protein. Those two proteins connect to the promote of the myogenesis. So the recovery of the damaged muscle fiber is also increase the PP1 protein or phosphatase 1. Okay, is involved in the modulation of many processes at the cellular and tissue level. So such as muscle relaxation, contraction, glycogen metabolism, inducing muscle function improvement, and also increase the actin and tropomyosin. Actin and tropomyosin are responsible of regulation of muscle contraction. Okay, so it promote muscle contraction effectively. Also the effect on the damaged tissue repair. So as we know that laser can promote the release of the fibroblasts, and the fibroblasts can create the collagen later. So laser can promote the increase of the collagen fiber density and also increase in the ATP binding proteins. So it can help in the better exploitation of chemical energy, mainly is ATP stored at the cell, and also increase the galactin-3 synthesis that is useful for restoration of capillary network. Also it can help to reduce edema. So we can use laser for the edema management. The method is just to induce the moderate the vasodilation or microcirculation at the cellular level, at the cell, okay, and it's reduce the fluid viscosity. Because of the vasodilation, the blood come more, and it help reducing the fluid viscosity. So it's promote the come and go of the blood, and so the circulation is much more better through the photothermal effect. All right, okay. So we know the physiological effects of the laser briefly. So we're gonna know about the indication, what cases or what kind of patient we can use laser. So mainly we can use laser for the tissue healing. So maybe like a muscle, any injury to the muscle, we can use it. Muscle healing for the tendon, for the nerve. So if you have the patient with the radicular syndrome, like the back pain and radiate to the leg, so this is the nerve impairment. You can use the laser to promote the healing of the nerve as well. And also you can use the laser to relieve pain. So this is the basic two indications for the laser. However, we need to be careful in some condition that is considered as a precautions. For example, the patient with impaired sensation, the patient with reduced reflex response, that might be not so safety for the patient to be used with the laser. So you can use it with caution. Okay, you can ask the patient step by step and to be careful that to look carefully to the patient's skin, not too red, not too hot, warm, not too hot. Okay, so the patient with the impaired sensation, you can use it with caution. And also at the reproductive organ for male, it's just the testis, and in the woman is in the ovary area, so in the lower abdominal area. And also for the epiphyseal plates in children. So for example, at the wrist, at the wrist, at the leg of the patient, the children patient, right? For the children is growing, so the long bone have the epiphyseal plate. So we do it with caution because the epiphyseal plate can, make the bone longer and longer. So the epiphyseal plate work very hard, and laser might have some effect on the epiphyseal plate activity. Also for the infected area, so we are very very cautious in this area because the infected area, we don't know inside. So the laser might promote some vasodilation, and we cannot control the infection. So we do it with caution, or we can do other area, not the infected area, or we can just skip on that day. And also for the sympathetic ganglia as well, because the sympathetic ganglia is very sensitive to the light or to the laser. For example, at the vagus nerve, also and the chest area, the patient with the heart conditions. Also, we need to be cautious at the tattoo, because the patient with the tattoo, no matter color tattoo or black tattoo, is absorb light and absorb laser very well, so it get hot and get burned easily. Also including for the oil tattoo, also including for the pen ink. So as a PT, we don't use the pen to mark the area because the pen ink can absorb laser as well. So it can come to the burn at the ink covering the area of the skin. And also in the dark skin patient, we can just be careful at the area that, for example, if the patient have some marking, like a black marking or like a skin skin pathology that make that skin have some darker area. So we try to do it with cautions in the pigmented area as well. All right, for the contraindications, we don't use it absolutely. The first one is the fetus, okay, because the fetus have the very quick development inside. Okay, so we don't do it at the area of the pregnant woman in the fetus area. And also at the eye and surrounding area, not eyelids, not eyes, because the eye can absorb light very well, so it's very dangerous. And also for the tumor in the cancer patient, we don't do it. And for the bleeding area, because the bleeding area is just still bleeding, and the laser promote vasodilation, so it can create more bleeding, so it cannot control. And also for the area with the venous thrombosis, phlebitis, and arterial disease. All right, I just show you for the example of my study, my team study. So this is just newly released at this year. So my trend and my lab we now just try to study for the efficacy of high intensity laser therapy. And this study we just use for the single session only. And we see pre and post comparison, that what happened if we just only one session to be used in patients with knee osteoarthritis. This is a pilot study. So we saw that only one session the patient can have immediate pain reduction as well. However, our study just the pilot and sample size is very small, so we encourage to do more with the larger sample size and we can monitor in the longer term. All right, this is another study of our team. We use the high intensity laser compared with the shock wave therapy in individual with plantar fasciitis. Okay, and it's published in Laser in Medical Science Journal. Okay, 2 years before. If you're interested in, you can search for the evidence as well. All right, terima kasih. Thank you very much for your attention. Okay, I think Q&A session is waiting.
Okay, so thank you very much, Achan. That was thoughtful and thoughtful presentation sessions. So participants and students, maybe you have something who want to discuss or want to ask, please deliver your questions. The question and answer is open. You do welcome. Yeah, okay. There's one questions in here. There's one participant who want to ask.
Okay, thank you for the time. Let me introduce myself. My name is Patricia Adindadelo. I'm from nursing student. My question is, given the variability in laser parameters, wavelength, energy density, pulse duration across studies, how can standardizations in high intensity laser therapy protocols be achieved to ensure reproducibility and clinical reliability across diverse patients populations? Thank you.
Sorry, could you
Achan, do you
type
get
me
the
for the
question?
question? Could you type me the question in the
Oh,
chat
okay,
box,
okay,
please?
sure.
Thank you.
Wait. It is about the standardizations of the high intensity laser therapy.
Great. Thank you very much, Nikmatu. Okay. According to your question, so the question is, given the variability in laser parameters, for example, wavelength, energy density, and pulse duration across studies, how can standardization in high-intensity laser therapy protocols be achieved to ensure reproducibility and clinical reliability across diverse patient population? Okay, thank you very much. Okay, for your question. The first one that I would like to share is that the laser have the different as the question say. So many model, many brands, it has their own, like energy density, right? Has the pulse duration that is very different. So I think the first one is that the wavelength. Okay, according to that I show you the wavelength. So the wavelength that is commonly used in the laser therapy for physical therapists is about 800 until 1000 nanometer. Okay, for this range of the wavelength, 800 to the 1000, that is very good. Okay, for the tissue in our human body. Okay, so the wavelength that is not so wide, is about 800 and 1000. That is okay. That is okay for the tissue absorption. And for the energy density, this is a good question. Energy density, that is just only one parameter that we can adjust from our machine. So I just suggest you to think about 4 joules for the superficial area and for 8 to 10 joules for 1 square centimeter area in deeper structure. Okay, so this is a recommendation from the WALT that recommend you use not so high density, because if you too high, this is the overdose. If you use too less, this is underdose. Okay, that is not so good. So I just suggest you to use the optimum dose. So my study, I just claim that according to the recommendation, I use 4 joules for the superficial tissue, 4 joules per square centimeter. So if your subjects, if your patient have, for example, like an area to be treated, 10 square centimeters, you can apply 40 joules if it is superficial, or 80 joules if it's deeper structure. And the last one is the pulse duration. The pulse duration is just, like a fixed parameter from the model, from the laser. So you cannot adjust it, okay? For the pulse duration is the engineering inside that the laser company just produce. You can read the manual. So the thing that we can consider for the pulse duration is that for the high intensity laser therapy, if the pulse duration is very wide, for example, it's like a many millisecond, right? It's so very wide, is cause more dangerous for the burn. If the laser company create very thin, the pulse duration is very thin, is so good because the pulse duration is very thin, is reduce the risk of the burn. If the pulse duration only in the microsecond or not many milliseconds, it's like a 0.1 millisecond or 0.01 millisecond, that's very good, okay? So the pulse duration not so wide, it's so thin, it's very good because it reduce the risk of the burn. Okay, so according to study, so nowadays, the study in high intensity laser therapy not so much. In the manuscript, the researcher just try to explain that what model of the laser they use and what the parameter, that is a fixed parameter according to the laser model. And only the one thing that they just adjust for the energy density only. So according to the energy density and the area of the treatment, it comes to the total energy that the researcher use, just that. So I think nowadays the variety of the energy density not so wide because we have the recommendation from the WALT, not as the previous study. The previous study had, very variety because we have no idea before. But nowadays we have very close, we have very similar. And I think you can stick on like a recommendation of the WLT by the energy density calculation. Okay. So when you use the laser, if you found some previous study, use the same model with you, you can study their parameter in the manuscript, okay? And you can just try to make the parameter to be close to the thing that you can gonna apply to your patient as well. If the model of the laser in your unit or in your clinic not the same, you can study that some parameter might be similar, right? And you can just try to calculate for the energy density only. That is the one thing that you can do.
Okay, thank you very much, Anton. That was a clear answer. Is there any participant want to ask? Okay. One more participant that asked.
Yes. First of all, let me introduce myself. My name is Ibnu Saluri Dilama, and currently I'm a physiotherapy student in my third year. So I have two questions for you, and questions number one is, in which stage of injury rehabilitations in high intensity level therapy most effective, acute, subacute, or chronic? Okay, next to the second question. What is the most effective, the techniques of application, non-contact techniques or contact techniques for any diagnosis or any case of physical injury?
Can you repeat the second question? The second question.
The second question is, what is the most effective techniques of application between non-contact techniques or contact techniques for any diagnosis of physical injury? Okay.
All right. Thank you very
Thank
much.
you so much.
For your, okay. Thank you, Nimatu, as well. Okay. Thank you very much for your very good question. So the first question, that in which stage of injury or rehab is healed most effective? I think since the healed or laser therapy is good for the ATP synthesis, so for the acute and subacute effective the most, because the acute or subacute stage, right, is have the inflammation, is have the tissue maturation. Okay, so if you gonna treat the patient with the acute or subacute injury, this is very effective. So when you get a patient and patient report to you that they just have this acute injury, so you can treat it immediately. Okay. So also for the chronic case, you can use it. If you think that the patient still have some pain, okay, that the pain can, you can identify that the pain at some structure, at some muscle, or at some tendon as well. Okay. So because for the chronic cases, they might have recurrent injury that is very possible. So for the chronic case, you can treat it as well. Okay. So the answer for the first question is that acute and subacute effective the most, but you can also use for the chronic case as well. If you if you are sure that the muscle or the target tissue still have some problem, still have some strain, have some injury that needs some healing as well, because some chronic case have some recurrent injury as well. And the second question, what is the most effective techniques of application, non-contact or contact technique for injury? So if the skin of the patient is okay, if the skin of the patient is intact, I suggest you to use the contact technique, okay? Because the contact technique reduce the reflection. So the reflection is reducing. It means that you get the rays of the laser beam a lot to touch, to penetrate to the target tissue. But when you use non-contact technique, it can create more reflection. So it's reduce the it's reduce the laser beam to penetrate to the target tissue. So I think just only two things that be careful to use with the contact technique is that the first one, some skin lesion. Don't use it with the patient with skin lesion because it can be risky for the skin infection, right? So it's very dangerous. So the skin lesion, we don't use contact technique. And the second one, that some model of the laser say that this model cannot use the contact technique because it increase the risk of burn. So if some model at your unit say that you cannot use the contact technique, you're supposed to use with some distance from the probe to the skin. For example, they suggest you to use for at least 10 centimeters. You're supposed to be obey to this instruction, not to use the contact because it can give the risk of the burn. All right. Otherwise, if they have no two restriction, you can use the contact technique.
Okay, so for the acute and subacute effective the most, right? I done. And then for the contact technique is better than non-contact technique. Okay. Actually, there are other participants who want to ask or discuss. I think that's all. Actually, I have myself one question. Ajahn, do you hear me well? Can you hear me well? Sorry. Ajahn, I have questions. Considering the current evidence of the laser, would you recommend laser compared to other physiotherapy interventions? What do you think about that?
Okay, I think I just do the research by comparing between laser and shockwave therapy, right? For the plantar fasciitis, that is like for the plantar fasciitis, it has some pain at the heel. So the pain at the heel is mean that the inflammation is ongoing. So my result found that for the shockwave therapy and laser can significantly reduce pain. Both of them can reduce pain significantly. However, other measure that I did is to measure the skin blood flow. It found that the skin blood flow is reducing at the laser therapy. It means that the laser can promote inflammation goes away really quickly. However, the shockwave therapy can create more and more, like because the shockwave have the mechanical effect, right? So it creates vasodilation more and more. So it means that it's just to be, it's linked or it's related to the vasodilation all the time. So sometimes the patient can tell you that they have some, some soreness or some, like a recurrent pain. That is very possible after the application of shockwave, like today or tomorrow, okay? But in the long term, both of them is effective for the plantar fasciitis. So, but I didn't see many studies to compare. I think the trend we can use for like a comparison between two techniques in the future study as well. because we can make the decision, right, to select the modality that is effective, that is cost effective, that is you can, like a shorten duration of the treatment. So I just encourage for the future study as well.
Thank you very much, Achan. I think that's all. That's the end of the Q&A sessions. Thank you so much, Achan Prasad, for the insightful and inspiring presentations. We truly appreciate you taking your time to share your expertise with us today at HSIC 2025. It's been an honor for me to learn from you again, and we wish you here maybe next time, maybe in the future. Achan, thank you very much.
All right, thank you very much. Thank you, everyone.
With that, I'd like to hand the floor to the MC. That's all from me. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Ms. Ninin, and our second keynote speaker. Ladies and gentlemen, we will move to the third session. The third speaker will be delivered by Professor Su Wu from Taipei Medical University, Taiwan, and Mrs. Agustin Rafika Yanti, as from MSc, will be the moderator. So, to Mrs. Vika, without any further ado, time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Welcome to the 4th Health Science International Conference with the theme Applied Technology for Sustainable Health. I am Mrs. Vika, and it is my honor to serve as your moderator today. On behalf of the organizer, I warmly welcome our distinguished speakers, participants, and guests. This conference brings together expert practitioners and learners to share knowledge, insight, and experience on the adverse drug reactions from psychopharmacological treatment, from presentations of the Professor Wu Sehua. We hope this event will inspire collaborations, new ideas, and meaningful discussion. The Q&A sessions will be held at the end of the presentations. And let me to introduce our speakers today, Professor Wu Sehua, PhD, from the Department of Clinical Pharmacy, Taipei Medical University. Professor Wu is a leading researcher in therapeutic drug monitoring with a special focus on neuropsychiatry, pediatric, and biomedical nutrition to improve patients' outcome. She has published over 40 scientific papers and serves as an editorial board member of the Journal of Taiwan Pharmacy, as well as a reviewer for multiple international journals. Beyond researchers, Professor Wu contributes to public health policy as a member of Health Food Review Committee as the Food and Drug Administration's Ministry of Health and Welfare in Taiwan. Her work spans biochemistry, pharmacotherapeutics, and drug utilizations evaluations, making significant contributions to both clinical practice and academic development in pharmacy. The presentation's title is Adverse Drug Reactions from Psychopharmacological Treatment.
Please join me in welcoming Prof. Wu Zhihua. Professor Wu?
Can you hear me?
Yeah, your voice
Okay,
is
great.
clear.
Yeah. Thank you for your introducing me, and also I like to express my appreciation that the UMM invited me to share some of my scientific experience and publications to the audience. And since today's conference is trying to focusing on the applied technology for the sustainable health, then the original title, which is adverse drug reactions from psychopharmacological treatment, would later on in the content, I will try to mention one of the technique that my colleague and student work together to fulfill this topic. And because of the time limitation, so instead I mentioned the outcome of the publication at the end. I'd like to show in the beginning of the slide, and which is work together with the psychiatric doctors, who is Dr. Lu Mongliang, and who is also right now as president of the Biopsychological Society in Taiwan. And the second author, who is chemistry professors, and who is experts in LOC mass. And as you mentioned, as you can see on the slide, the right-hand side, that I point out the key technician, which is LOC mass. And so in this publication that my past graduate student, PhD student, Nalis, who is also right now on the screen, and I really appreciate that his efforts and contributing to this study, and also as a very nice teaching assistant to help master degree student who is a fourth author, who we always call her as Eva. And right now she is also a clinical pharmacist in TMU affiliation hospital, and we're very outstanding. And also and so forth, that because the time limit, then if at the end that because I realized that the voices, I mean from the Indonesia, that because I didn't prepare my earphone, maybe later on cannot hear the local voices, then perhaps Nalis can help me to answer those questions if a student or audience would like to raise. And okay, so let's go on to the story of the today, which is about the adverse drug reactions. And so in the beginning, I would like to start up with the pharmacist's duty, which is very important to find out the drug-related problem from patients' therapies, especially pharmacotherapy. And in Taiwan, we follow up the European guidance, which is called as a PCNE, and they have classification or documents that allow pharmacists to follow up and make sure that they did each part of the check for the codes and also for the problems. So today, I only focusing on the second one of the treatment safety, which means that even doctors and pharmacists were very hard to make sure the treatment efficacy is very good, but all the outcomes of the patients always compromise with the treatment safety, and that is what we call adverse drug reactions. And so if even the drug, not just drug induced, and sometimes the patient themselves has a physiology issues from those problems. So, but of course, later on I will give examples of that related to LOC maximus study about the folates. And in the beginning, I'd like to give a short definition for the adverse drug reaction for the audience students, and which means potentially hazardous or unpleasant reactions that occur as a result of procedure associated with the use of medical substance. So that means the adverse drug reaction in the pharmacy department, usually we are more concerned about the severe adverse drug reactions, and which is usually we need to report to the government and also talk to the doctors to make sure that when they prescribe, they need to make sure that patients don't face the severe, for example, death risk. But in fact, from the point of view of the pharmacotherapy outcomes, that because if patient has unpleasant feeling to what they are taking, to the drug what they are taking or what the doctor prescribed, then patients usually kind of give up to get pharmacotherapy. So in my study patient, which is schizophrenia patients, then they will cannot get the adherence to the treatment, and of course their mental illness will be not only harm to themselves. Sometimes those schizophrenia patients may give harm to the other peoples. So it's very important issue that in the psychological treatment that to make sure patient needs and like their drug treatments. So from the classes of the drug, this slide I like to show there are three most common atypical antipsychotic side effects. And of course, those medications are on market and work very well, but again, their side effects, or what we call about adverse reactions, may hinder the patient to follow up our medication orders. So for example, the main three of those are sedation, weight gain, and EPS. But EPS is mostly occur in the old classes of the drug, and for example clozapine. But the clozapine is also a very effective medication for patients. So usually the doctor will put the selection of using clozapine as the last line of the selections. And so right now, mostly good use of the about to have less EPS. That means a patient has EPS means a patient has a tremor with their hands, and maybe make trouble for them to have a everyday life, to like taking the phone or eating. And so usually nowadays risperidone and paliperidone is very nice, but today mostly we're focusing on the weight gain. For the sedation is kind of dilemma, because some of the patient needs sedation side effects in the beginning of the treatment, because usually they have trouble sleeping, and so usually sometimes in the beginning doctor will choose sleeping the antipsychotic medication with sleeping side effects initially, to make sure patient gain healthier and also
also gain their cognitions, because after they have good sleep, they can understand and normally to talk to doctors or pharmacists. And so today I would like to focusing on the weight gain issues. And for example, olanzapine, which is another one of the old atypical antipsychotic, and which is usually studied on the patient which under the prescription of the Dr. Lewis. And for the fact, but for example, the gain weight, when we think about weight gain, usually in the beginning we just think, oh, your shape is not good. But in fact, after the long time of the weight obesity, then we will see additional problem from the blood test, what we call as homocysteine, because homocysteine will increase with the increase of the weight, body weight, and which will come from different issue factors. For example, lifestyle. So when people not only have the weight gain from the drug treatment, and sometimes sometimes they have coffee consumption to make sure they don't feel sleepy if they took the olanzapine, which also has sedation side effects. And when people has schizophrenia, because then they usually those patients has decreased interaction with people, so usually they will stay at home and decrease their physical activity. And about the smoking problem, then there is some reference. They do the epidemiology and find out that 70% of the schizophrenia patient has a smoking habits. So all those come together to increase the homocysteine. And the homocysteine is also further identified as a risk to have a CVD, that means cardiovascular disease, and then also with the others problems. So initially, homocysteine considered as a biomarker that for the side effects of the antipsychotics, but with the increased technology, then developed and more story that try to find out what does the issues or factors or proteins behind the weight gains. And so, as I mentioned, that olanzapine is one of the antipsychotic drug or central nervous system medication induce the significant weight gain, which means that according to our previous study, patient can gain 4 to 8 kilogram within 3 months. So it's very significant problem to those patients, even they are under very well olanzapine treatment. So so that when I mentioned here again with the slide, but I try to point out is another factors, which means is there any others factors also contribute to the homocysteine in addition to the obesity and lifestyle habits? Yes, in this slide, it points out that the enzyme deficiency, for example, B12, folate, and B6, and also in addition that the folate synthesis also resulting from problems of the genetics, especially on this enzyme. And so next slide, I'd like to explain a little bit of the so complicated two cycles. And these 2 cycles including the folate metabolic pathway and this methylation process, and we need to know that two cycles or this pathway work together with the methionine cycles, and so on. That we can expect that if one of the cycle, maybe I should turn on this way, and the right hand side cycle is go this way, and if one of the cycles has a problem, then we'll make trouble to the other ones. For example, if we can see that if patient has deficiency in the nutrient of a B12, that will cause reduced conversion of the homocysteine into the methionine, and the deficiency of the B12 will also hinder the 5-methyl THF, which is the active form of the folate, back to the cycles. And so that means that if from the point of view of the nutrition, B12 is very important to the schizophrenia patient also. But the interesting story is because doctors know about this story, and then they try to follow up patients, the schizophrenia patients and nutrition, especially on the B12 and also on the folate. But after years, they give up. But why they give up? Because they found out that even patient has sufficient folate go to this cycle, and if even patient has sufficient B12, adequate nutrition of B12 or B6, but patients still not get very well outcomes with the efficacy or even the adverse reactions. So we eventually doctor talked to us, and then even though they are so frustrated, and so but when we look at the two cycles, usually we call as a one carbon metabolisms, and we just think perhaps we can try to measure the active form of folate, because perhaps patient has a sufficient adequate folate intake, because the patient, the family take good care of them, but maybe the patient has inside the genetic problems of the methyl reductase. So, but in the beginning, to measure the SNP, maybe cannot answer the question, because we never know whether the levels of the 5-methyl THF is good enough to the patients. So in our laboratory, we work together with the Furen University and spend 3 to 5 years, eventually to set up LC methodology platform to measure, including the active form of folate and also betaine, which is also a food. We can get it from every day, and also DMG, and because we try to understand whether the deficiency or adequate of the THF here would do anything to change the metabolism of the methionine cycles. And the answer is here. In the recruiting participant, we get the database from the biobank of the Seneca, the Taiwan biobank for the healthy controls. And we have our own recruited schizophrenia patient, and so we go on to take their blood, and at the treatment stable steady state, and then we not just measure the 5-MTHF, and we also determine their PON SNP, and also the one I just mentioned, C677, this site. And we found out that, as you can see here, healthy control has around 22 nanomolar, which is very low levels of the 5-MTHF. So that means our platform is very sensitive to measure these concentrations. And in comparison to the healthy controls, schizophrenia patients has almost half of the levels, and the two group has significant differences. And so we really exciting at that time when we just look at this data. But afterwards, we still start to think why those patients why those schizophrenia patient has low levels of the 5-MTHF. But of course, we cannot always talk to the family who taking care of the schizophrenia patient and to measure how much they eat, to count whether they took whether they intake the sufficient of the folate. But we further try to analyze their SNP, and so on. We can see here there are very rare few people has SNP here, only 2 here, which is a little. If based on the percentage, is around half of those also. And the population is also significant difference in this site, the SNP size. So we are have a conclusion that we identify the schizophrenia patient has a significant lower levels of 5-MTHF, and in fact, when we talk about whether it's adequate or inadequate, we always need to have so-called as recommended levels. So in fact, we cannot have a conclusion that the healthy control has adequate 5-MTHF, but we can say that the schizophrenia has less. But of course, we always the global healthy the institute perhaps need to discuss that whether how much 5-MTHF is sufficient to the healthy conditions. And again here that from the previous analysis that we also plot comparison based on the polymorphism, and we can see that even in the healthy controls, the SNP didn't do much differences to contribute to the levels. But the schizophrenia patient, even this group, there is no significant changes neither. So, but of course, we can see there are so many outliers from the patients. So I believe the problem may be because when we recruited, we didn't set the criteria that whether patient has a sufficient intake of the folate. So in this issue, perhaps in the futures, any laboratory need to recruit more patients to answer the question that how the polymorphism to change the converting of the precursor of 5-MTHF. And okay, and then let's go back to the patient's overall view that because when we talk about pharmacotherapy, the outcome from the whole body is what clinical pharmacy need to taking care of. So from the point of view of the again with the homocysteine, as I mentioned, it's not just about the what we call the one carbon metabolism with the folate or the B12. It also will cause different of the side effects. For example, heart failures and also glucose metabolism. And again, maybe here is a very novelty issues, which is osteoporosis. Usually patients treat with polyperidol or risperidone. They have risk of increasing very significant with their prolactins. And so after the long-term treatment, then the patient will have a problem, very severe problem of bone loss. So right nowadays, Dr. Lu already continues several years of study, try to recruit more patients to monitor the problem, the issue of the osteoporosis. But let's go back to what the slide here. The slide from this study, which we published 2022, and this study is trying to find out that how early we should do to taking good care of patients' heart failures. In the beginning of the slide, I also mentioned about smoking habits, very common thing in the schizophrenia patients. So here is one of the slides that I want to tell the audience or the student to keep in mind that when we look at the schizophrenia patient, we not just look at his brain, his mental illness, we also need to take care of their heart, because to decrease this study has a conclusion that to decrease cardiovascular mortality in those schizophrenia patients should be started in the early stages of psychosis. And in fact, it also reflects to the clinical wards that when patient has acute psychosis visiting to the hospital, all the doctors always prescribe that to measure their EKG, which is to monitor their heartbeats. And here is another story to support what I just mentioned, that the authors also try to measure the elevated pulse pressures. And so that means sometimes students will raise the question that, Professor, you said we need to look at their heart health, but how we do that? And so here is I share one of the papers I read about that they try to just do simple measurement of the pulse pressures. And so together with this study also measure together with the pain score, which at the bottom of the table to reflect to the control status of, the treatment status of the patients. Okay, and now my slide just go to 13. I know the time is, I'm losing the time, and so perhaps later on I will jump to the other factors, very short reminding to the audience. In addition to the weight gain or obesity or the cardiovascular issues, for example, in patients if they increase their ages, and especially if they are females, then the increase of the side effects also come together with the 1/5 of the percentage of the hypertension and metabolic diabetic mellitus. And here also this study mentioned about anemia. So in our laboratory, we also study focusing on the irons, and because I work together with the rare disease department, which is focusing on the thalassemia patients who are also anemias. They need to have blood transfusions. So I think for the anemia, in fact, some of the nutrition involving the blood production, I hope the audience would pay attention in the futures in your countries. And here is the figure to support that previous study about the increasing ages of increasing side effects. And here it gives additional medication, which is lithium. Lithium would produce the highest percentage of the more frequency of the side effects. But lithium is not the antipsychotic drug, but it gives very well control when patient has a bipolar disease. And more recently, there are several studies that to identify, to measure the lithium level in the nature foods. So here is additional information that I myself also feel exciting, that because from the point of view of the pharmacological therapy, the pharmacy always know that there is a drug very effective, which is called as a lithium, but we never think about that the nature food also include lithiums. So perhaps the prevalence of the taking food with the safety levels of lithium is also very important issues in the future to look at. And at the end of my talk, I'd like to mention again, because I always promote this study because in Taiwan, the government also hoping that academic laboratory to promote traditional medications. And so in Taiwan, we also have a drug which is commonly used. For example, I highlight here is a ginkgo and ginseng, and those are summarized by a review article that they found that is commonly seen in the together with the neuropsychotic medications. And so in the future, we also need to take a look in addition to whether those medication perhaps they have a very trace amount of the lithium, and perhaps so on to help patients altogether, not just treated with the Western medications. And my laboratory has set up a website, and which is published earlier in the 2019. And at that time, Nalis also joined this study, and the contribution of her is also focusing on the English the writings, because this website include the publication from the articles, but as we all know that patients or pharmacy, they don't really like to study the articles writing because it's hard to understand and tricky. And so Nalis and I work together with the other clinical pharmacy is to make sure that the wordings in the database is short but is good enough to make people understand, and so we can promote very good idea that if they themselves took herbal treatment and together with the Western medicines. And now is maybe I only have 5 minutes to go. So, but before that, I would like to highlight a definition to the audience and students is that to understand, make sure that we all understand that there are two different terms, which is complementary, and another one is alternative. When we call the herbal medicine is a complementary treatment, that means we think that traditional medicine can work together with the Western medicine, and they can contribute good control of patients' disease status. But if the traditional herbal medicine can do even very well alone without the Western medicine. So from the clinical medication evidence, that if it shows that, for example, ginseng can treat very well alone, then we can call it as alternative therapies. So usually I remind my students who are they are senior pharmacists. I always remind them that to tell the patient or the customers, and just make sure that they are not just like to eat herbal medicine. They need to know how severe their disease. If only take herbal medicine without the Western medicine, they need to understand that they may have a risk because the selective herbal may only have the complementary roles in their drug management. Okay, and so here is the list of the evidence that we use to evaluate the literatures, and so we in the website we also give the herb drug interaction with the reliability score to make sure that the pharmacy or the readers, they know the story of the interaction, whether it's reliable enough or not. Of course, when we say likely, that means okay, the interaction may have severe and occur during the co-medications. And at the end, I'd like to have some funds for the students. So if the chair allow the audience or student to use their mobile phone, perhaps they can crop the QR code here, so they can start to play with the website I just mentioned about drug-herb interaction. And here, this website, the goodness of this website was included in recent review articles, and the value of this website is because it's bilingual. As you can see here, it's English, and also when we choose, they can show the Chinese. So the people who I know in your country may have customers can read the Chinese also. So perhaps they can use this one to their everyday life once they have needs. And sometimes when the people operate the website, they feel some of the trouble or difficulty in the beginnings to find how to operate. And here also another QR code that I prepared some website searching step. So, and this step is also including in the publications. So the student can try to learn, and pharmacy can help customer to use also. And here is go back to our story of today. Then, for example, I mentioned that ginkgo usually commonly used in the neuropsychological treatments. And here is 3 articles, and here is possible, and these 2 are likely. That means based on these 2 article studies, they give us comments that the possible of the drug interaction with the ginkgo and the haloperidol. And the implication of the ginkgo, they say, the treatment may enhance the effectiveness of antipsychotic drug and reduce their EPS. So as based on these examples, here tells us that the ginkgo, the herb, can not just enhance the efficacy of the drug, antipsychotic drug, and also can reduce the side effects. So I think I would like to use this one as comments to this talk, and hopefully that in the future we have more chance to meet together. And behind several slides is additional information that if the pharmacy student would like to look at the importance of the story today, that support the following documents on the slide is to support the previous talk in slides. Okay, thank you for your attention.
Thank you very much, Professor Wu, for the insightful presentations. And now we open the floor for the questions. Please raise your hand or maybe chat in the box if there's any. Kindly introduce yourself before delivers your questions.
Okay, welcome.
Taipei Medical University.
Okay.
My name is Nashwa. I am from nursing student. Thank you for the insightful presentation, Prof. I am curious, why is clozapine considered the worst choice for sedation and weight gain, but the best choice for extrapyramidal symptoms? Thank you.
Okay, Professor Wu, do you hear the questions clearly? Hello, Professor.
I cannot hear very well, so
maybe I can type for you.
Perhaps Nadis can help with that.
Okay, I will help you with that. Yeah.
Thank you. Sorry.
Okay, please, can you replay to deliver your questions again? Yeah.
Why is clozapine considered the worst choice for sedation and weight gain, but the best choice for extrapyramidal symptoms?
Why?
Why is clozapine,
yes,
considered the worst choice for sedation and weight gain?
Okay, considers.
But the best choice for extrapyramidal symptoms. Extrapyramidal symptoms.
Okay, I already text for you in the chat box. Yeah.
Okay, I saw the one of the student asking that why clozapine consider the worst choice and the best choice.
Oh, Mrs. Nailis add some explanations.
Perhaps I can share the slide again. That I think the student confusing about the questions, and these two questions also come from that the same slides. So let me share the slide again. Okay, and here is a very important slide, I guess, for the student. And for this slide, I get it from the information from this website, just for audience convenience. But I would suggest students to find a meta-analysis from the recent studies. Perhaps knowledge can help work together afterwards for the students. And but based on this slide, we can because time maybe I went through too fast, so I take a couple minutes here to explain again. The best choices is here, and then the worst choice is here. When we talk about best, that means a good choice, and for the worst choice, that means no good to the patients. And when we see no good from this slide, that means those side effects will be very severe, very severe from for example, the clozapine and quintilpine. But as I mentioned, the EPS here, if it's all classes of the antipsychotic drug, but if compared to the first generation of here, in fact, is still the risperidone still have slight EPS, but all those are considered good enough if it's compared to the first generation of antipsychotic. So I know that when I went through this slide, I didn't mention about this story here, but just to mention, but just focusing on the weight gain. So it's very good that the student raise the question, and of course they feel confusing. The side effects always in comparison among the medication of selections.
Okay, thanks for the answers. Are there any questions? Is there any questions? Okay, maybe that's all, Professor Wu. Thank you for your comings. Thank you for your engaging discussion. Oh, we already we have once more. Okay, sorry, Professor Wu. We still have one question.
Oh, okay.
Okay, first of all, let me introduce myself. My name is Ibnu, and I'm currently studying as a physical therapy student in my third year. So I have one question, and my question is, how to prevent adverse from drug interactions that you explained before, like herb and neurotherapy drugs?
Can anybody type the questions
Okay,
as a brief? Oh, okay. It's a very how you mean you the question is how to prevent adverse drug reaction from herb drug interaction, right? Yeah. Thank you very much for your questions. So from the adverse drug reactions, then from now on, it's even more complicated if we can see that perhaps mostly commonly seen is when people took the alternative, or if they take the herbal medicine themselves, and they hide the story, they hide their actions to the doctors or to the pharmacist. So usually it's really hard to prevent that herb-drug interaction. But nowadays, the purpose of my set up the website for the herb-drug interaction, yes, this is my idea of the hoping that the pharmacy and also the patient or consumers, they start to notice that there is a problem possible if they took herb and drug together, if they don't talk to the professionals. So I guess this is what I can answer you, and hoping that all the audience start to pay attention to this. Even though the herbal medicine or the conventional medicine is good, but always hoping that patient can tell us without the hidings, so we can know how to help them. Okay.
Okay, thank you very much for the
Okay.
answers. Once again, for the audience, thank you for the engaging sessions. As we come to the end, I would like to thank to the all speakers, participants, and the organizers. Professor Wu, I will to conclude what your presents. Professor Wu emphasized the managing adverse drug reactions in pharmacology requires more than just adjusting medications. It calls for personalized care that consider patients' factors, pharmacogenomic and interactions drug risk. And then we hope today insight will be valuable and further collaborations. Thank you very much, and I wish you hope a productive day ahead. See you soon. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you. Bye bye.
Thank you, Mrs. Fika, and our third keynote speaker. We will continue the agenda, which is invited speaker session. The speech will be delivered by Mrs. Nuraini, PhD, from Department of Nursing, University of Muhammadiyah, Malang. For this session, we would like to invite Mrs. Heni Tri Rahayu, PhD, as moderator to the stage.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning all, Honorable Dean of the Faculty of Health Sciences and distinguished participants. Ladies and gentlemen, I'm Heni Tri Rahayu. It gives me a great pleasure to be the moderator for the fourth speaker of the fourth Health Science International Conference 2025 held by University of Muhammadiyah Malang with the theme Applied Technology for the Sustainable Health. So, ladies and gentlemen, first I'd like to read the brief introduction to our fourth speaker from University of Muhammadiyah Malang, who is with us today in here, Mrs. Nuraini, PhD. The first is she is the lecturer in the nursing program of Faculty of the Health Sciences of University of Muhammadiyah Malang. She has graduated from the Doctor of Nursing, Taipei University in 2021 and 2025. The Dr. Nuraini is majoring about the basic nursing science, meta-analysis, biostatistics, neurocognitive and psychological intervention related to sleep also. So she has many research and publication related to this. And for right now, CS will talk about the dementia, if I'm not mistaken, right? Okay, the first about, please welcome to our speaker, Dr. Nur Aini, to present his presentation on the topic, the effect of light therapy on cognition, sleep, and depression in people with dementia. For about 20 minutes, Dr. Nur Aini, time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, for Dean of the Honorable Dean of Faculty of Health Sciences, Committee of Health International, Committee of Health Science International Conference, and all audience. Thanks for the opportunity for give me to present my research in this event. Here I will share my research with title The Effect of Light Therapy on Cognition, Sleep, and Depression in People with Dementia. According to WHO, dementia is a umbrella term used to describe a set of symptoms that can include changes in memory, thinking, perception, judgment, reasoning, language, attention, and concentration. And it must be severe enough to interfere with a person's ability to function. While ICD-11 defines the dementia as the presence of impairment in two or more cognitive domains, representing a decline from the individual levels of functioning. Dementia is global health challenge. Each year, 10 million new cases diagnosed per year. And currently, it is estimated that over 50 million people worldwide living with dementia. Alarmingly, dementia is now the 7th leading cause of reason for death in the world. In addition, according to the recent projection, the number of people with dementia worldwide is expected to increase from 46.8 million in 2015 to 131.5 million in 2050. And how the dementia in Indonesia? Dementia research in Indonesia remains limited, particularly at the provincial level. Research found the prevalent rates in Java and Bali more than 20%. This opens up opportunity for the future research. In 2016, Indonesia had approximately 1.2 million people with dementia, and by 2030, this will increase to 2 million. Why in Indonesia the population of dementia will increase? Because the prevalence of dementia is projected to rise substantially with aging population, posing significant challenges for healthcare system and social support structure. Economic burden of dementia. Dementia is not only a health problem, it is also economic challenge. In 2015, the global cost of dementia about 818 billion US dollar. Just 3 years later, it had already reached 1 trillion. And by 2030, it is expected to double to 2 trillion. If dementia carries a country, its economy will rank 18 in the world, bigger than companies like Apple and Google. Globally, dementia imposes substantial economic burden through care costs and loss of productivity. However, the economic burden of dementia in Indonesia has not been precisely quantified. Risk factor of dementia. The risk factor of dementia comprises two, non-modifiable and modifiable factor. For the non-modifiable, such as age, sex, and genetic background, and for modifiable factor, including early life, middle life, and late life. If we can control the modifiable factor, the risk of dementia will decrease 45%. People with dementia have physical and mental health problem. For the physical, such as sleep disturbance, and for social, such as psychological well-being or depression. 60 to 70% of dementia patients have sleep disturbance. Sleep and circadian rhythm disorder occur due to the neurodegeneration in the SGN. And poor sleep quality in dementia will worsen cognitive decline and psychological well-being. Light therapy. Light therapy is treatment that use artificial light, mimicking sunlight, to improve physical and mental health condition. Light therapy is safe and cost-effective non-pharmacological intervention for dementia. Why people with dementia need light therapy? The first, circadian rhythm, which are regulated by the SGN, are often disrupted due to the aging-related age changes and neurodegenerative process. The SGN generates and synchronizes circadian rhythm. Light is the most essential stimulus that synchronizes the circadian pacemaker. And the last, the circadian rhythm function as the body's timekeeper to synchronizing sleep, metabolism, hormone, mood, and immunity with the external light dark cycle. Light therapy can be delivered in groups, like this picture, or individually. And there are many light therapy devices, like such as light box, desk lamp, like visor, or down simulator. Types of light therapy. Light therapy consists of some types, such as bright white light, red light therapy, blue and rich light, and green light. They have different intensity and intensity or lux and wavelength. Here the example of benefits of light therapy. For example, for bright light therapy, it have effect on sleep improvement, enhancing mood, anxiety, depression, and also can improve cognition. And the next for red light therapy shares some benefit with bright light, but also have additional effect, such as for skin rejuvenation, for pain management, for wound healing, and also for hair growth stimulation. And for blue light therapy have additional effect, such as anti-inflammatory and bacteria, and reduce skin problem, and also reduce fatigue. And for green light therapy also have some have similar benefit, but additional effect is for eye comfort. Mechanism of light therapy. From this figure, it can be concluded that light therapy will induce SGN, which often refer to the brain circadian rhythm or biological clock. The circadian rhythm influence sleep, wakefulness, hormone release, body temperature, cognitive function, mood, and other psychological process. And the next effect of light therapy is for regulate the pineal gland by inhibiting melatonin and melatonin production in the morning while increasing serotonin level. Serotonin level is feel-good hormone that associated with happiness, relaxation, and increased daytime activity function. For the methods, the design of our study is meta-analysis. We register other study in the Prospero and Follett Prisma guideline. We search the database in the 9 databases and also manual search in the Google Scholar and previous published systematic review or meta-analysis. For the inclusion criteria were population, people with dementia or mild cognitive impairment, intervention was like therapy, any comparison for the outcome, cognition, sleep, and depression, and for the studies design, we use RCT. Two independent researchers will screening by title abstract and then full text, and also contact author for obtain missing data. For data extraction, we extract the data based on the diagnosis, setting, country, population characteristic, and also intervention characteristic. After that, we conduct quality assessment, use ROB2 that consists of 5 domains, and the result will categorize into low, some concern, and high risk of bias. For data analysis, we use CMA software for analyze the data with a random effect model, and the data will presented as effect size HSG with 90% confidence interval and prediction interval. And for the additional analysis, including heterogeneity test, publication bias, moderator analysis, and sensitivity analysis. The result, in total, we included 24 studies that published between 1998 and 2022. And here the some characteristic of included study. The majority mean age was 78.52%, and the majority is female gender. The effect of light therapy. Our meta-analysis found that that light therapy significantly improved cognitive function with HSD 0.39. And the second, light therapy significantly improved sleep quality, total sleep time, and also improved sleep efficiency. And the last, light therapy significantly decreased depression. Next, for the study quality and publication bias, the majority of our study have low and some concern of risk bias, and we found publication bias on sleep efficiency, but after performing the trim and fill method by adding two studies, the effect size changed to 0.26. Next, for the moderating factor, we found frequency. It means that we give twice light therapy in the morning and in the evening, significantly reduce the depression in the people with dementia. And for the sensitivity analysis, after we exclude studies with high risk of bias, study with sample size less than 30, measuring outcome using different instrument, and also applying what study remove technique, the sensitivity result did not substantially alter the overall finding. That indicates our study's robustness. For the discussion, first, the effect of light therapy on the cognition. Light therapy will activate cortical and subcortical network, enhancing alertness and cognitive performance. And the next, light therapy will modulate key neurotransmitters such as glutamate that have function for learning and memory, melatonin that have function for sleep and circadian rhythm regulation, and serotonin that have effect on to improve mood and cognition. Improved mood further enhance attention, memory, and decision making. And light therapy also will influence the circadian rhythm and memory formation in the people with dementia. The second effect is for sleep. Light therapy is stimulus that synchronize the circadian rhythm. Light therapy is stimulus that synchronize the circadian rhythm for better sleep quality. Specialized retinal cell in people with dementia or elderly will receive light input and relay it into the SGN. The SGN have function to regulate and synchronize circadian rhythm, thereby facilitating stable sleep pattern, melatonin secretion, psychological activity, and emotional regulation. The last is the effect of light therapy on depression. Light exposure inhibits melatonin and stimulates serotonin production, enhancing alertness and reducing depressive and anxious symptoms in people with dementia. And light therapy also will improve mood, agitation by regulating circadian rhythm. For the significant moderator, we found that twice daily of light therapy or giving the light therapy in the morning and in the evening have significant effect to reduce depression. Why this can reduce depression? Because morning light plays crucial role in resetting body's biological clock, with help boost alertness and reduce daytime fatigue, particularly in individuals with dementia. It also will suppress melatonin production early in the day with enhanced mood and cognitive function by stimulating serotonin. On the other hand, for the evening light, light exposure is beneficial for improving sleep and reducing nighttime agitation. Next, for the conclusion, the first, light therapy improves cognition, sleep quality, and reduce depression in people with dementia. And the second, twice daily of light therapy significantly moderates its effect on depression. However, we didn't found the significant effect of frequency of light therapy on sleep and on cognition. And the last, overall, light therapy is promising and cost-effective non-pharmacological intervention for dementia. Implication: healthcare providers can implement light therapy to manage symptoms of dementia and enhance quality of life. Future RCT studies can involve a large sample size and extended follow-up period and comprehensive demographic data, because we found limited included studies that conduct a follow-up or long-term effect of light therapy. And the last, if we have limitation such as financial or resources to apply light therapy, it can be replaced with natural sunlight exposure, because natural sunlight exposure, especially at 7 to 9 EM, have a same intensity or lux with light therapy. That concludes my presentation. I hope it provides new insight and inspire for further research. Thank you for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much for Dr. Nur Aini for giving the such information and comprehensive presentation about the sleep and cognition and about light therapy for this part. Ladies and gentlemen, we are now going to have the discussion with our speakers. So if I would like to invite our participant to raise your hand and address your question. Maybe one or two questions. Yes, please. The guy from middle, please. The microphone, please. State your name and come from what department.
Yes, thank you, Miss. Let me introduce myself. My name Marsal Nafisa Ulum. I'm from nursing student 2022. My question is, consider the variability in intervention protocol across studies. Example, type of light therapy, intensity, duration. How do you suggest clinician standardized light therapy for dementia patient in real world practice to maximize its benefits on cognition, sleep, and depression?
Okay, you got it?
Thank you very much for the question. That's a good question. In our study, we conduct meta-analysis study. Meta-analysis study, it means that we compile all RCT study that previously have conducted the light therapy for people with dementia. But actually, light therapy is not also benefits for people with dementia. Light therapy also can be implemented for health people or people with other disease. Or you still have many opportunity to conduct light therapy in the patient. Or such as that I mentioned before, if we have limitation such as for the financial or resources to implement light therapy, such as in Indonesia, we can replace it with natural sunlight. And currently also limited research about the natural sunlight exposure for people with dementia or for other clinic for other people. So you can conduct for your thesis or future research if you continue your study. And regarding your question, the meta-analysis based on the evidence-based practice, meta-analysis is the highest evidence. So we can implement this intervention in the practice. But such I mentioned before, for the implementing related to the patient condition, if we have limited resources, we can replace it with natural sunlight because natural sunlight also have same intensity with light therapy. Is it my answer clear?
You got your answer, Asa? Okay? Okay. Maybe one more question? Yes, please. Siapa? Oh, Juan. Okay, Juan dulu deh. Please, Juan.
Okay. My name is Juan Mardika, and I wanna ask one question. Your result highlight twice daily therapy as a significant moderator for reducing depression in dementia. What potential challenge might arise when implementing this regimen in long-term care facilities, particularly in low-resource setting, and how could this be addressed?
Okay, thank you very much. Actually, for the moderator analysis, we conduct or we analysis all factors that influencing the implementation of light therapy, such as the demographic characteristic, the characteristic of intervention, such as the device of light therapy, intensity, frequency, and the distance. But the significant effect only frequency. It means that we give twice daily of light therapy in the morning and in the evening. And why only significant for depression? Because our limitation in our meta-analysis that we found limited studies in the sleep that perform twice daily of light therapy for the sleep. So the majority the result only on depression that give twice. For the normal person, if we give the evening light for the normal person, it can be depress the or suppress the melatonin production. But it's different with people with dementia. For people with dementia, because they have problem in circadian rhythm regulation and also problem in the production and system of melatonin. So for dementia, giving the light therapy twice in the morning and evening will more have benefits.
Okay, are you got it? The
Okay,
answer?
clear.
Okay, thank you. We have one more question, is okay? Okay, I think the girl will raise your hand, please. It is the last question. One more question, I think.
Okay, thank you for the opportunity. Let me introduce myself. My name is Fieka Mandru Afida. And as how can light therapy be integrated with other non-pharmacological interventions such as music therapy or cognitive activities in dementia care? Thank you.
Okay, thank you. For the people with dementia, actually they have two interventions, pharmacological and non-pharmacological. But for the pharmacological intervention for people with dementia, have many adverse effects. So we can conduct the alternative intervention such as the light therapy. And actually there are many non-pharmacological interventions for people with dementia, not only light therapy. We can also implement such as music therapy or physical exercise or dual task training. And light therapy is a simple and cost-effective intervention. So it can be integrated with other interventions such as music therapy. For example, people when give the light therapy, they also listening for the music, so we can conduct together.
Okay, that's a very detailed answer to the question, Dr. Noraini, and I think it's enough. Now we have come to the end of the session. I would like to thank to the speaker, Dr. Noraini, PhD, for your informative and interesting presentation, and also to all of the participants for their active participation. Please give applause, big applause to our last presenter today. And I close this session. Wassalamualaikum warahmatullahi wabarakatuh.
Profesor Dr. Yoyo Bekti Prasetyo, M.Com. Certificate to Mrs. Nur Aini, PhD. Ladies and gentlemen, the next agenda is oral presentation. If you oral presenter in second session, we invite you to join the oral presentation in room A, B, and C. Room A in 308 room. Room B in 309 room. Room C in 310 room at the 8th floor. Please be informed that the room assignment for all oral presenters are posed next to the next exit door and also in front of each presentation room. You may check your assigned room there before proceeding to your session. And after the oral presentation session, we hope all participants can join the announcement and closing ceremony back to this room. In addition, lunch is available at the coffee break table, and you may take it before proceeding to your assignment room. Okay, once again, to all participants can lunch and coffee break. Please enjoy the refreshment that have been prepared at the coffee break table. Thank you.
Oke, apa ya? Bapak Ibu dan juga adik-adik sekalian, mungkin kita take a photo together dulu ya. Ya, group foto before you start your lunch. Kita foto dulu biar nanti ada dokumentasi di pagi hari sebelum nanti harus ada yang berhalangan untuk foto dulu. Jadi kami undang Bapak Ibu, mari kita foto dulu sama-sama. Tadi kita belum sempat ambil dokumentasi di pagi hari. Ya, sebelumnya nanti setelah itu monggo nanti bisa istirahat, sholat dan makan. Monggo, Prof. Yoyo, Bapak Ibu, adik-adik peserta yang sudah hadir, Bapak Ibu, monggo kita foto dulu.